right? And this session is mainly based on discussing previous year question papers, and we will be discussing, apart from those, some other important points that is not included in that question. Okay, shall we start right now? To start with, let me not waste much of your time. To start with, first question: for assessment of adequate response to ventilation during the process of neonatal resuscitation, which among the following is the best way? Change in color? Yes, as you mentioned already, a change in color. If the child is cyanosed and if there is no cyanosis, then it indicates that the ventilation is not proper. So can I say this one is correct? Let's wait. Second one is chest rise. If the child did not show any improvement in oxygen saturation even after ventilation, we will be finding it out whether there is an adequate chest rise or not, because majority of the time your ET tube will be in the esophagus. So chest rise is an indication for appropriate placement of endotracheal tube in the trachea rather than being in the esophagus. Third one is respiratory rate. Definitely not so, because when the child is not doing well with the respiratory failure or apnea or gasping, invariably we are not going to find in terms of the respiratory rate. Even though I can say change in color is correct, change in chest rise is correct, indicates a correct ET tube placement. But one thing that we need to know is increase in heart rate, because as you all know, the successive steps of neonatal resuscitation is mainly based on increased in the heart rate. So how do we classify actually an heart rate of less than of usually when your heart rate is less than 100, invariably you will start, the first step will be you will start positive pressure ventilation after initial steps of resuscitation. After initial steps of resuscitation, invariably you will start your steps of resuscitation invariably at the end of 1 minute. 1 minute is the time by which, if the child doesn't show any increase in heart rate, you need to start positive pressure ventilation, otherwise known as bag and mask ventilation, right? Second one. Okay, so bag and mask ventilation, and we will use bag and mask ventilation for about 30 seconds to look for whether the heart rate is going to increase or not. Whether the heart rate is going to increase or not. If the heart rate is more than 100 per minute, we will discontinue ventilation. More than 100 per minute, we will discontinue ventilation. Okay, if the heart rate is 60 to 100 per minute, then there will be some problems. 60 to 100 per minute, then if it is not rising, means we will do Mr. Sopa. What do you mean by Mr. Sopa? You will change the position of the mask, you will reposition the neck, you will suction the mouth, you will open the mouth, you will give adequate pressure over the bag and the mask. And if nothing is possible, then you can go for either endotracheal ET tube or a laryngeal mask airway. If the heart rate is more than 100 per minute, so one is more than 100 per minute, discontinue ventilation. If the heart rate is 60 to 100 not raising, means Mr. Sopa. And finally, if the heart rate is less than 60 per minute, I repeat, if the heart rate is less than 60 per minute, then you will give what you will give, less than cardiopulmonary resuscitation, and you usually 120 events per minute, 90 chest compression and 30 ventilation. 90 chest compression and 30 ventilation. This is how you go. So remember, your neonatal resuscitation is mainly based on the change in the heart rate. Okay, it doesn't mean that you need to rely on the color or chest rise or respiratory rate. So this is very, very simple. And what are all the other things? So the answer is improvement in the heart rate. Second point, can you answer, is there any role of RL? Point number one. Is there any role for RL in neonatal ventilation? Can anyone, if you are able to answer, you can post in our chat box. Is there any role for RL? No, RL should not be given. I repeat, RL should not be given. Be previous, even in OP guide, RL was mentioned. RL should not be given because if the child is in apnea, there will be an underlying lactic acidosis. So we cannot exacerbate the process by giving RL. RL should not be given. So the fluid of choice is normal saline or O negative blood. So what is the indication for normal saline or O negative blood? Very simple. Even after 1 minute of chest compression as well as bag and tube ventilation, if the heart rate is less than 60 per minute, if the heart rate is less than 60 per minute, then you need to give adrenaline after normal saline or O negative blood bolus. The dosage of adrenaline is normal available adrenaline is 1 in 1000. 1 in 1000, we will dilute 1 ml of adrenaline with the 9 ml of normal saline to make it 1 in 10,000 adrenaline. And in that 1 in 10,000 adrenaline, we give, okay, we give 0.3 ml per kg, okay, followed by saline bolus, followed by saline bolus. Then another question, potential questions are, if the child doesn't have any umbilical vein route, what are all the other routes you can give? So one is umbilical vein, second one is peripheral vein, third one is endotracheal route, third, if nothing is possible, you can give through intraosseous route. And one more questions that recently they had added is, what is that? Delayed cord clamping. And the another thing is delayed cord clamping. What do you mean by delayed cord clamping? So you need to cut the cord 30 seconds to 60 seconds after birth. After birth. Right. So these are all some of the questions that can be potentially asked apart from the one which is asked in this question. Then going for the next one. What is this? In patients with the hyperkalemia, which one of the following will not be used in emergency? Okay. So in patients with, let me see whether you are answering or not. Okay, very good. You are answering. Endotracheal tube. In patients with the hyperkalemia, which among the following will not be used in emergency management? So let me wait for your answer. A, calcium gluconate. B, IV magnesium sulfate. C, salbutamol. D, injection insulin and dextrose. The question is not used. Not used. Some of them are opting for Sindhu C, Sakti C, Nishita B, okay, Doctox B, okay, Sapna B, okay, right. So remember, okay, even when you have a life-threatening hyperkalemia, what do you mean by life-threatening hyperkalemia? Life-threatening hyperkalemia means when your potassium is more than 7 milliequivalent per liter. That is life-threatening hyperkalemia. Along with that, you can have T wave, tall T waves. You can have P wave shortening. You have PR prolongation. These are all the things that can happen with the hyperkalemia. You can have QRS prolongation, and finally you have sinusoidal wave, and it leads to diastolic arrest. It leads to diastolic arrest. Okay, right. So this is all about hyperkalemia. And when you, what is the management of choice? You need to stabilize the membrane. Membrane can be stabilized with the help of calcium gluconate. Membrane stabilization is occurred with the help of calcium gluconate, right? There is nothing to do with the potassium reduction. The purpose of giving calcium gluconate is to stabilize the cardiac membrane. So what is the dosage? Usually 1 ml per kg of 10% calcium gluconate. IV infusion over 20 minutes is the treatment of choice. Right. So what is the role of salbutamol? Salbutamol makes potassium to go inside the cell. What is the role of insulin? Again, insulin causes potassium to go into the cell. Apart from that, so calcium gluconate can be used, salbutamol can be used, insulin along with the dextrose can be used. Apart from that, you can use K-hexylate. What is called K-hexylate? It can be given either through oral route or it can be given through enema. So what is the role of K-hexylate? It is a potassium binder. It avoids potassium from absorption from the intestine. K-hexylate. Right? What are all the other things? The other things, ultimately, if nothing is possible, you can give hemodialysis. The final thing is hemodialysis. So this is all about hyperkalemia management, the ECG changes in hyperkalemia. So what is the answer? The answer is IV magnesium sulfate. IV magnesium sulfate doesn't have any role in hyperkalemia management. But I would like to ask one question to my students. My question is whether the same magnesium sulfate can be given in any cases related to potassium. I will be waiting for your answer. Is there any possibility of using IV magnesium sulfate in relation to potassium? Waiting for your answers. Looking at your answers in your YouTube. What is that TDP? What is the role of magnesium with respect to potassium? Leave alone that hyperkalemia. A beautiful question can be framed. There is a relationship between potassium and magnesium. What is the Torsades D pointers? Potassium and magnesium. Remember, so whenever you talk about hyperkalemia, the next thing you can talk about hypokalemia. The next thing you can talk about is hypokalemia. Okay, hypokalemia. So what are all the management options in hypokalemia? Yes, as you told, your answers are correct. What are all the other things with respect to hypokalemia? Let me complete this session on hypokalemia. Hypokalemia management is whether the potassium is less than 2.5 milliequivalent per liter. If it is so, you need to look for whether there is ECG change present or ECG change absent. When you have a ECG change present, you can give IV potassium. When you don't have ECG changes, you can give oral pot chlor syrup. Apart from that, apart from hypomagnesemia, is there any role of magnesium in any electrolytic disturbances? Yeah, very good. KCl IV, ECG showing U waves, correct. IV pot chlor. Is there any role of magnesium with respect to any other electrolytic disturbances? Waiting for your answer. Is there any role of magnesium? Very good, very good, very good. So remember, when in all cases of hypocalcemia, if the child is not responding to IV calcium gluconate, then you need to give magnesium sulfate. Very good. So magnesium sulfate is mainly given in cases of documented hypocalcemia not responding to calcium infusion. That is the role of magnesium sulfate. Very good. Happy with your answers. Very good. Right. So identify the X-linked dominant disorder from the following. So basically this is a pathology questions. I don't think I need to discuss so much on X-linked dominant. But whatever it might be, so what are all the X-linked dominant disorder? You all know Rett syndrome. Apart from that, speak in terms of pediatric cases. One is Rett syndrome. Second one is incontinentia pigmenti. Second one is incontinentia pigmenti. Third one is X-linked hypophosphatemic rickets. Third one is X-linked hypophosphatemic rickets. Okay, and fourth one is orofacial digital syndrome. Orofacial digital syndrome. So these are all the conditions in pediatrics which are commonly associated with the X-linked dominant. Okay, right. All part very good. Most common are hypophosphatemic rickets, right? So can anyone tell me what are all the possible questions that can be asked with respect to, okay, I'll try to change it. Okay, Pudi, I'll try to change it. Okay, what are all the possible questions that can be asked in Rett syndrome? Rett syndrome, whenever a girl is brought with periodic, okay, periodic, okay, writhing movements. What is called writhing movements? Periodic writhing movements. Along with that, acquired microcephaly. Along with that, acquired microcephaly. Microcephaly. So any child with very good neuroregression, acquired microcephaly, okay, very good neuroregression. You need to think in terms of Rett syndrome, and you all know it is associated with the MCQ mutation. MCQ mutation. This is called periodic writhing movements. Okay, Rett syndrome. So what are all the possible questions that can be asked with the spinal muscular atrophy? Because it is very, 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 very important. Spinal muscular atrophy. Anyone? Spinal muscular atrophy. So any child with any floppy infant, frog leg position, frog leg position, undescended testis, undescended testis, absent reflex, absent reflex. Apart from that, can anyone tell me? Very good, lower motor neuron palsy, very good. Verdict Hoffman, Dubowitz, and third one is Birding Hoffman, Kugelberg, Wallander. But Birding Hoffman is more than necessary. Can you tell me what is the important finding with respect to clinical finding to diagnose spinal muscular atrophy? Clinical finding to develop spinal muscular atrophy. Okay. Clinical finding to find out spinal muscular atrophy. Anyone? Tongue fasciculations. So, tongue fasciculations. Tongue fasciculations. Okay. No. It is not CKMB. The clinical point with respect to spinal muscular atrophy is tongue fasciculation. Right. The next is for what is the manifestation of ornithine transcarbamylase deficiency? Ornithine transcarbamylase deficiency is an inborn error of metabolism, and it is X-linked recessive. It is X-linked recessive, and it comes under urea cycle disorder. It comes under what? Urea cycle disorder. Okay. And what will be elevated in case of urea cycle disorder? In case of suspected urea cycle disorder, your urine orotic acid will be very, very high. Urine orotic acid will be very, very high. Yes, hyperammonemia. Urine orotic acid is the screening test for ornithine transcarbamylase deficiency. One of the very few inborn errors of metabolism that is X-linked recessive, because majority of your inborn errors of metabolism are autosomal recessive. And finally, what is the finding for Duchenne muscular dystrophy? What will be the manifestation of Duchenne muscular dystrophy? So any boy who comes with motor developmental delay, and as you all know, Gover sign is usually established by 6 years. And the screening test for in this case is CPK will be normal. CPK is less than 150 milligram per deciliter, but here it will be in thousands. CPK will be in thousands, right? In the thousand. So what is the investigation of choice? The investigation of choice is PCR analysis. Choice is PCR analysis to look for exon deletion. To look for exon deletion. Very, very important. Duchenne muscular dystrophy is often asked question. One more point is cough hypertrophy. Cough hypertrophy. And another point I would like to ask my children, death due to respiratory failure. What is the manifestation of this Duchenne muscular dystrophy in girls? What is the manifestation of Duchenne muscular dystrophy in girls? Apart from cough hypertrophy. Dharani, apart from cough hypertrophy. It is someone told mutation in dynin. Sri Raj, you are wrong, my dear. It is mutation in dystrophin gene. It is mutation in dystrophin gene. It is not dynin. Mutation in dystrophin gene. Dynin is usually associated with Cartagena syndrome. Is usually associated with Cartagena syndrome or primary ciliary dyskinesia. Dynin mutation. It is not dynin. It is dystrophin. So intrauterine death not at all possible. No, weakness. No, it is. Yes, it is. What is the manifestation of DMD in girls? That is my question. The manifestation of, because it was once asked. Okay, I'll try to change my handwriting. So what is the manifestation of Duchenne muscular dystrophy in girls? The manifestation of Duchenne muscular dystrophy in girls is arrhythmias. In girls is arrhythmias, or it, I repeat, no, the manifestation of Duchenne muscular dystrophy in girl is arrhythmias, right? So this is with respect to some of the knowledge that we gained with respect to our third question. Now let's go to the next question. In an HIV positive mother, which among the following is correct about the management of the baby born who is to be exclusively on top feed? So I will be waiting for your answer. I will be waiting for your answer. Baby is on Zidovudin even before the result of HIV testing is available. If replacement feeding is being given, no prophylaxis is required. Replacement feed and Zidovudin to be given for 6 months even after the child is HIV negative. Baby is tested for HIV and given Zidovudin only if the baby comes out to be positive. Right. I am waiting for your answer. Baby is tested for HIV and given Zidovudin only if the baby comes out to be positive. C, D, anyone else? The child is on top feeding. A, C. Okay, there are some confusions with respect to this question. Remember, I don't bother about whether the child is on top feeds or breastfeeds. That is not an issue. When the mother is HIV positive, as soon as after birth, mother is HIV positive, as soon as after birth, what I will do? I will start nevirapine prophylaxis. I will start nevirapine. This is, I am speaking about NACO guidelines. I am starting nevirapine prophylaxis, right? Nevirapine prophylaxis for low risk cases. For low risk cases. For high risk cases, I will give both nevirapine as well as Zidovudin. I will give both nevirapine as well as Zidovudin. So how long you will give nevirapine prophylaxis? Nevirapine prophylaxis will be given for 6 weeks. In case of high risk, both nevirapine and Zidovudin will be given for 12 weeks. 12 weeks, very good. Will be given for 12 weeks. Then what I will do? I will check at the end of 6 weeks. I will check dried blood spot to look for PCR HIV. I will see whether it is positive. If it is positive, again I will do dried blood sample to look for PCR. I will do dried blood spot for PCR. If twice it is positive, then I will put the patient on child on ART. I will put the child on ART. If it is negative, stop nevirapine. If it is negative, stop nevirapine and cotrimoxazole prophylaxis. Cotrimoxazole prophylaxis for about 12 to 15 months. Cotrimoxazole prophylaxis for about 12 to 15 months if it is negative. What about breastfeeding? Okay, breastfeeding can be continued. What about breastfeeding? Breastfeeding can be continued till 1 year. Breastfeeding can be continued till 1 year, and after that, no need to for sudden change to weaning. It was there as a previous concept. It is not so. You can do gradual weaning. You can do gradual weaning. Not an issue. You can do gradual weaning. So whether the child is on top feeding or the child is on mother feeding, immediately after birth you need to give Ziduvudin. Okay, immediately you need to give Ziduvudin. Okay, gradual weaning is accepted, very good. So if replacement feeding is being given, no one knows whether the child, because the most common cause time for transmission is perinatal period. One. Second one, Ziduvudin we don't give for 6 months, low risk cases 6 weeks, high risk cases 12 weeks. Baby is tested for HIV and given Ziduvudin only if it is positive. No, you can't wait for it. So baby is started on Ziduvudin even before the HIV testing is available. This is the latest NACO guidelines. Don't wait for it. Whether the child is in breastfeeding or whether the child is in top feeding, please start Ziduvudin as soon as the baby is born. Don't wait for the result. Okay, right. So the answer is A. Okay, the answer is A. Next question. For the management of sickle cell anemia, okay, for the management of sickle cell anemia, which of the following, the question is, cannot be used? Which of the following cannot be used? So waiting for your answer. High risk, low risk. Someone asked high risk and someone asked low risk. Okay, Foodie, let me tell you what is called high risk. So remember, if the mother took ART, for more than 4 to 8 weeks before delivery, mother's RNA copy is less than 1000, means it is low risk. It is low risk. Again, HIV-1 is positive, means low risk. Then what is called a high risk? Second one is high risk. So what is called a high risk? Mother took ART during pregnancy period only less than 4 weeks. Second one is RNA copy is more than 1000. Third one is along with HIV-1 if you have HIV-2. Okay. And mother detected HIV only at the time, of pregnancy or only at the time of breastfeeding. So these are all the low risk cases. So 1, 2, 3 are low risk. This are high risk. In the first 3 instances, choose Levirapine for 6 weeks. In the next 4, you need to choose Ziduvudin and Levirapine both for 12 weeks. Okay? Right. Thanks for remembering it. Right. So sickle cell, back to sickle cell. For the management of sickle cell, which of the following cannot be used? Which of the following cannot be used? L-glutamine, oxylotar, peptilovib and hydroxyurea. Answer? Yesterday you had a great class with the Sarath sir. So what is the role of these drugs in case of sickle cell anemia? Anyone? Waiting for your answer. Many, all of you know that the treatment of choice for sickle cell. So what is the treatment of choice for sickle cell? What is the treatment for choice of sickle cell? All of you know. Okay, leave alone this. So C. So except majority, yes, all of you know. So what is the role of C then? What is the role of C? Okay, right. In sickle cell anemia, the first treatment is hydration. Sickle cell anemia means the first it is hydration. Second one is analgesia. Third one is hydroxyurea, which converts sickle into hemoglobin F. Third one is hydroxyurea. So hydration, analgesia, hydroxyurea. Other treatments are exchange transfusion. Exchange transfusion, otherwise known as plasmapheresis. Okay, exchange transfusion to make the sickle cell levels less than 30% in case of acute chest syndrome. In case of sequestration crisis, acute chest syndrome, sequestration crisis, in case of priapism. Okay, and then stroke, in all these cases we used to do exchange transfusion, remove all those abnormal sickle cell to make the sickle cell percentage less than 30%. So hydroxyurea, all of you know. So what is the role of this L-glutamine? Can anyone tell me what is the role of L-glutamine? Tarani Sindhu had answer for A. No. Glutamine reduces. I repeat, my dear friends. Glutamine reduces addition. Glutamine reduces addition of sickle cell to endothelium. Addition of sickle cell to endothelium. Which one? Glutamine. So what is the role of voxelotor? It prevents polymerization of sickle cells. It prevents polymerization of sickle cells. Prevents polymerization of sickle cell. One more drug that prevents polymerization is, look at this. Okay, crizanlumab. This also prevents polymerization. This also prevents polymerization. So finally, what is the role of then? So this drug is not used, bebtelovimab. So this is used in, this is here monoclonal antibody used in COVID. This is here monoclonal antibody is used in COVID. So L-glutamine is used, voxelotor use, crisanlumab is used, hydroxyurea is used. C is wrong answer. C is used in COVID. It is a monoclonal antibody used in COVID-19 cases, right? Okay, very good. So this a little bit of tougher question, but you have learnt three things. L-glutamine prevents addition. Paxilotar prevents polymerization. Crisanlumab prevents polymerization. Hydroxyurea, hemoglobin F formation. Bebtelovimab is used as a monoclonal antibody for admitted COVID-19 cases. Very good. Right. Then, okay, in which of the condition there will be a congenital absence of vas deferens and seminal vesicle? Such an easy question. Okay, such an easy question. Cystic fibrosis, testicular feminization syndrome, Kalman syndrome, and tuberous sclerosis. Answer is okay. Bilateral absence of vas deferens and seminal vesicle. So cystic fibrosis is characterized by bilateral absence of vas deferens, bilateral congenital absence of bilateral vas deferens. So what we call it as in cystic fibrosis, congenital absence of bilateral vas deferens. So all males are sterile. All males are sterile in cystic fibrosis. All males are sterile in cystic fibrosis. Right. So what is the manifestation of testicular feminization syndrome? What is the manifestation of testicular feminization syndrome? Anyone? Kallmann syndrome, you all know. Kallmann syndrome is delayed puberty. Kallmann syndrome is delayed puberty along with anosmia, absence of smell. Delayed puberty along with anosmia. Testicular feminization syndrome comes under disorders of sexual differentiation. Disorders of sexual differentiation. So usual manifestation will be phenotypic male. So what is the manifestation of testicular feminization syndrome? Yes, please answer. Testicular feminization testicular. So testicular feminization syndrome will be suspected, particularly feminization syndrome, particularly when you have a girl with primary amenorrhea. He is not a girl, actually it's a boy. Girl with primary amenorrhea, with breast development will be there. Breast development will be there. Okay, and usually there will be a history of bilateral hernia, or they would have undergone herniatomy. The irony is that a hernia contains bilateral testes. Okay, bilateral testes. So feminization at puberty. I repeat, feminization at puberty. Feminization at puberty without primary amenorrhea is the manifestation of testicular feminization syndrome. Yes, they are males, right? Very good. Since there is no adrenarche, there will be no hairs. Very good. There will be no hairs. Now you tell me one more question I will ask. A girl suddenly become boy at puberty. A girl will suddenly become a boy at puberty with much enlargement of clitoris. Much enlargement of clitoris. And clitoris is so big. Oh, so big, and it mimics a penis. So what is this? What is this? Androgen insensitivity syndrome. What is this? It is very good. It is 5-alpha reductase deficiency. It is 5-alpha reductase deficiency. Otherwise, one more name for that is penis at 12 syndrome. It is there in your Ghana. It is called as penis at 12 syndrome. Which one? 5-alpha reductase deficiency. Right? Right. Kallmann syndrome explained. The manifestation of tuberous sclerosis, as you all know, a mental retardation. You have mental retardation, adenoma sebaceum, ash leaf macules, okay, cortical tubers, okay, cortical tubers. So many things with respect to tuberous sclerosis. So for this, congenital absence of bilateral vas difference is cystic fibrosis, right? Is cystic fibrosis common in India? Yes or no? Is cystic fibrosis common in India? Yes or no? Or it is a disease of Caucasian population? Answer. Cystic fibrosis is a disease of Indians too. No, it is a disease of Caucasian population. Yes means what? So we have been okay. Okay, no Sudhir, no Pankaj, no Sudhir, no Pankaj. Cystic fibrosis is very common in India. Cystic fibrosis is very common in India. Okay, both North India as well as South India. In our institute itself, we have around 50 mutation proved cases of cystic fibrosis. In Tamil Nadu, we have around more than 300 cases of CF. It is there in east, west, north, south. Now, okay, it is common. Now, now one more question based on the answers given by you. A child with tuberous sclerosis. One more sub question. A child with tuberous sclerosis is brought with hematuria. What is the answer? A child with, okay, a child with tuberous sclerosis brought with hematuria. What is the answer? Child with tuberous sclerosis brought with hematuria. What is the answer? Anyone waiting for your child with tuberous sclerosis brought with hematuria? So nothing but angiomyolipoma. Nothing, no angiosarcoma nahi hai, it is angiomyolipoma. They are nothing but hematomas, angiomyolipomas. Okay, very good. Child with, okay, your angiomyolipoma, okay, as well as cardiac rhabdoma. What is the fate of all those things? Cardiac myoma. What is the fate of all those things? What is the fate? You need a drug or self-resolving? Majority of them are self-resolving. Majority of them are self-resolving. If it is big, you can consider mTOR inhibitors like sirolimus, mTOR inhibitors like sirolimus, or you can consider everolimus. Okay, large angiomyolipomas and large cardiomyomas can require, usually they are self-resolving. If not, sirolimus or everolimus can be tried. Very good. Now, what is this? Next question. In a 5-year-old male diagnosed with a renal failure, the body was 15 kg, body weight was 15 kg and height was 100 centimeter. Urea was 100 milligram per deciliter and serum creatinine was 1 milligram per deciliter. What is the closest GFR? What is the closest GFR? Anyone? So what is that formula called as? What is that formula called as? So what is that formula called as? How did you calculate? I am waiting for your answers. Very good. So the formula is Schwartz formula. The formula is Schwartz formula. So what is to find out the estimated GFR? It is mainly based on constant K into, okay, height in centimeter by serum creatinine. The constant is usually 0.4 into height in centimeter, in that case 100, divided by serum creatinine 1. So what is it? 0.4 into 100, it comes around 40. So the GFR in this case is 40 ml per minute per meter squared of body surface. Per meter squared of body surface. 40 ml per minute per meter squared of body surface. So Schwartz formula is often asked one. Please listen to it. Definitely you will be getting one question in Schwartz formula or GFR. Very good. So this is Schwartz formula, right? Okay then. In the management of which of the following ACTH can be used? In the management of which of the following ACTH can be used? What is that? LGS is called as Lennox-Gastaut syndrome. Second one is Rolandic seizure. Third one is West syndrome. Fourth one is juvenile myoclonic epilepsy. Okay, so remember two important epileptic encephalopathy you need to know. So what do you mean by epileptic encephalopathy? Can anyone tell me? So you need to know something called epileptic encephalopathy, right? So what is called epileptic encephalopathy? Encephalopathy. Remember, if seizure is leading to, I repeat, if seizure is leading to neuroregression, if seizure is leading to neuroregression, then it is called epileptic encephalopathy. Two common epileptic encephalopathy for you are, one is Lennox-Gastaut. One is Lennox-Gastaut syndrome. Second one is West syndrome. Second one is West syndrome. Previously, we will call it as infantile spasm. Previously, we will call it as infantile spasm, but it occurs beyond infancy also. as a result of which the term has been redesignated as epileptic spasms. Epileptic spasm. And it is characterized by the triad of, what are all the triad of? One is neuroregression. Triad of neuroregression. Very good. And then salam attack, and then hips arrhythmias, and then what is the treatment for it? Two things: whether tuberous sclerosis complex present, whether tuberous sclerosis complex absent. If tuberous sclerosis complex is present, the drug of choice will be vigabatrin. If tuberous sclerosis complex is absent, either you can give ACTH. If it is not available, you can give steroids. Okay, you can give steroids. So this is about West syndrome. What about Lennox-Gastaut syndrome? So what about Lennox-Gastaut syndrome? It is also characterized by triad of neuroregression. Triad of one is neuroregression, and here multiple seizure type. Here it is multiple seizure type. You can get a tonic, you can get clonic, you can get myoclonic. So many things can happen. Multiple seizure types. Okay, multiple seizure type. Third one is spike. In EEG you will get spike and wave pattern. Spike and wave pattern. The treatment, they are treatment resistant. You can try valproate. You can try lamotrigine. You can try valproate. Okay, right. Try valproate. So Lennox-Gastaut over, West syndrome over, and Rolandic epilepsy. You will often, what will be the manifestation of Rolandic epilepsy? The mechanism of action is still not known, but it works. Okay, what is the manifestation of Rolandic seizure? The Rolandic seizure is usually present between 5 to 10 years. The other name for Rolandic seizure is seizure with frontotemporal spikes. What is that? Seizure with frontotemporal. Very good, very good. Seizure, someone told in sleep. Usually it occurs during early morning. Usually it occurs in early morning. With the involuntary movements involving face. Facial muscles. Okay, along with the drooling of saliva. The child will be partially conscious drooling of saliva. Usually occurs drooling of saliva. The investigation of choice is sleep EEG. The investigation of choice is sleep EEG, and you will get frontotemporal spikes. Temporal spikes. That is called Rolandic seizure. Temporal spikes. What is the drug of choice? The drug of choice is, can anyone? MRI will be normal. Can anyone tell me what is the treatment for drug of choice for Rolandic seizure? No, carbamazepine. The drug of choice will be carbamazepine, followed by valproate. It has got excellent prognosis. Right? So the answer is West syndrome. Right. Over. Next question. The height of a child will be half of this. The height of the child will be half of his adult height at what age? Can anyone tell me? Half of the adult height at what age? So let me write What is the, so is it 12 to 18, 20 to 24, 30 to 36, 48? Answer B, C, D, 2. So let me ask you some questions with this. So let me go for it. Now certain MCQs I would like to cover here itself. To start with, what is the height? What is the height at birth? Okay, what is the height at birth? What is the height at 3 months? What is the height at 6 months? What is the height at 9 months? What is the height at 1 year? What is the height at 2 years? What is the height at 4 years? What is the height between 6 to 12 years? Come on, answer. Okay, so at the height at birth is, I'm sorry, the height at birth is, what is that? 50 centimeter. At 3 months, it is 60 centimeter. At 6 months, 65 centimeter. At 9 months, it is 70 centimeter. At 1 month, it is 75. 1 year, it is 75 centimeter. At 2 years, it is 87 centimeter. At 4 years, it is 100 centimeter. And between 6 to 12 years, you need to gain 6 centimeter per year. You need to gain 6 centimeter per year. You need to gain 6 centimeter per year. So anything less than 4 centimeter per year. Very, very important question. Anything less than 4 centimeter year between 6 to 12 years indicate either you have growth hormone deficiency. Either you have growth hormone deficiency or you have thyroid deficiency. Thyroid deficiency. Growth hormone deficiency or thyroid deficiency. So the, what is the answer? The answer is usually, so answer is usually 2 years, in and around 2 years. The answer is usually 2 years. So compared to this one looks idle. So the answer is somewhere at 2 years, because at 2 years you are 87 centimeter, into 2 it will come around 165 centimeter roughly, your approximate adult height. So the answer is B, it is not C as many mentioned. Okay, so look, these things are very clear. This is an MCQ. At 4 years is an MCQ. Less than 4 centimeter per year is an MCQ. And remember, let me try to complete another things. When bone age is less than chronological age, what is the diagnosis? When bone age less than chronological age, what is the diagnosis? Remember, if it is less than 2 years, if it is more than 2 years, less than 2 years means it is constitutional growth delay. That is delay in puberty in father. The same delay is occurring in child. More than 2 years means it is growth hormone deficiency or thyroid deficiency. Growth hormone deficiency or thyroid deficiency. Whereas when bone age is equal to chronological age, it is familial short stature. It is familial short stature. When bone age is more than chronological age, it is precocious puberty. It is precocious puberty. Okay, precocious puberty. Tell me, a child with a short stature, okay, mid-facial hypoplasia, mid-facial hypoplasia, okay, infantile genitalia, and hypoglycemia in newborn. What is the diagnosis? Child had hypoglycemia in newborn. What is the diagnosis? What is the diagnosis? Short stature, midfacial hypoplasia, infantile genitalia, hypoglycemia in newborn. What is the diagnosis? What is the diagnosis? It is growth hormone deficiency. It is growth. This is also often asked a question. Growth hormone deficiency. Very, very important. This is growth hormone deficiency. Which one? Whenever you have a short stature with midfacial hypoplasia with infantile genitalia, and another clue is hypoglycemia in a newborn is always a growth hormone deficiency. This is also often asked question. Clue for a short stature. So this is all about short stature evaluation. Then what is this? Next question. Match the following developmental milestones with the timelines. This is not that difficult, I think. Okay. Only one ad is comfortable with that growth hormone deficiency. Remember, my dear friends, very short. The child is very short, doll-like faces, very short, doll-like faces, sometimes midline cleft lip or cleft palate, sometimes with the infantile genitalia. It's always growth hormone deficiency. So remember, social smile usually occurs, but what is this? Social smile usually occurs. Pincer grasp, you all know. Pincer grasp is by 9 to 11 months. Pincer grasp is by 9 to 11 months. Transfer of object is usually by 6 to 7 months. Walking within steps is 12 to 13 months. Social smile is usually by 2 to 3 months. Not much a difficult question indeed. Not much, yeah. So 1A, so pin 2C, 3 D and 4 B. So D is correct answer. Okay. Now let me ask you some simple questions. When the child will open the doorknob? First question. Open the. Let me ask some. Open the doorknob. Answer. When the child usually opens the doorknob. Anyone? Anyone? When the child opens the doorknob, it is usually 2.5 years. Not 4 year Tharani, it is 2.5 years. And again it opens the bottle cork. Opens the bottle cork by about same 2.5 years. Not 4 years, 2.5 years. Open the doorknob and open the bottle cork by about 2 years. That's why kerosene poisoning are more common between in 2 to 2.5 years group, right? So open the doorknob is by 2.5 years, right? Very good. So next question. This is also relatively a simple question. A pregnant female is expected to deliver preterm. The dose of dexamethasone to be administered for the purpose of fetal lung maturity will be answer. What is the dose of D? Okay, it's such a simple question. So you have beta dexa. So you have beta methasone. So beta is long acting. So beta is long acting. So you give 12 milligram, two doses, 24 hours apart. Whereas dexa is short acting. So you give 6 milligram, 4 doses, 12 hours apart for about 2 days. Tell me what is the absolute contraindication for this? What is the absolute contraindication for this? What is the absolute contraindication for this antenatal steroids? Anyone? The absolute contraindication will be chorioamnionitis. Chorioamnionitis. Okay, amnionitis. One more point, Sudhir. So how long you need to wait, and how long you need to wait for the delivery to occur after steroid, and how long it will last? How long it will last? Oh no. Asthma drug of choice is steroid, boss. What happened to you? Chorioamnionitis. How long you need to wait? So minimum 24 hours after giving steroid, and the effect will last for 7 days. The effect will last for 7 days. No, 48 hours nahi hai, Sapna. It is 7 days it will last. Other benefits apart from this, one is hyaline membrane disease, reduced intraventricular hemorrhage. One is hyaline membrane disease, second one is reduced intraventricular hemorrhage, third one is ROP incidence is also very low, fourth one is necrotizing enterocolitis is also very low. Okay, hyaline membrane disease, ROP, necrotizing enterocolitis, intraventricular hemorrhage. Benefits of steroids. Okay, I am going to give you one more case scenario. Let me see how many of you going to answer. I see a 30-week baby. I am much slower. I see a 30-week baby. Okay, by about 6 hours, the child developed respiratory distress. Respiratory distress. Okay, your Downey score is 4 by 10. 4 by 10. The Downey score is 4 by 10. Okay, X-ray, minimal GGO, minimal ground glass opacities. What is the treatment of choice? What is the next line of management? What is the next line of management? I am waiting for the sub question. I am waiting for the sub question. I am waiting for this sub question. What is the next line of management? 30 weaker, 6 hours after birth, develop respiratory distress, Downey score 4 by 10, X-ray, minimal ground. Next line. Next line of management is step 1. No, always start CPAP. Always start CPAP. Remember, my dear friends, no, PP marrow, instead of saying PPV, you give CPAP. Don't say PPV. PPV just giving positive pressure ventilation. So step 1 is CPAP. If CPAP fails, then you need to go for ensure. If ensure fails, you need to go for mechanical ventilation. Remember, we all are living in an era of non-invasive ventilation. Please do not think that all cases of hyaline membrane disease will be requiring surfactant. It is not so. I repeat, it is not so. Not all cases of hyaline membrane diseases will be requiring surfactant. Almost 70% of hyaline membrane disease will resolve with only pressurized oxygen, CPAP, because it opens the alveoli. It opens the alveoli and it provides positive end expiratory pressure, and thereby it opens the alveoli. So it is CPAP. It is not ensure. Only when the CPAP is not working, then you need to go for intubation, surfactant administration and extubation, and when it fails, mechanical ventilation. I repeat, one more point I would like to say. Okay, so CPAP, Downey score less than 4, CPAP is enough. If Downey score between 4 to 6, then ensure. If Downey score between 7 to 10, then mechanical ventilation. This will be a very simple thing to understand the concept. So Downey score less than 4, CPAP. Ensure when Downey score become 4 to 6 and mechanical ventilation 7 to 10. And remember, other causes are when you have apnea, go for mechanical ventilation, and when you have small white out lung, again you need to go for mechanical ventilation. Please make sure, my dear friends, do not get carried away with the term preterm. Preterm means even a preterm will resolve on its own with a simple CPAP rather than going for an intubation and surfactant administration. Okay, I think this is relatively tolerable handwriting. Indeed, the maximum I can try, right? Okay, now next question. Next question. In neonates, the causes of seizures will be hyponatremia, hypocalcemia, hypomagnesemia, hypernatremia. What is the answer? What marrow? See, I tried my level best to come to this level to get the appreciation from you people. Okay, what is this? In neonates, the causes for seizures will be hyponatremia, hypocalcemia, hypomagnesemia, hypernatremia. D. Very good. Since all my kids are started answering this, I am leaving it. But I would like to usually our purpose is to add a subtopic. So there are four types of seizure in newborn. One is there are four types of seizure in newborn. One is subtle seizure. One is subtle seizure. The second one is tonic seizure. The third one is clonic seizure. The fourth one is myoclonic seizure. Fourth one is myoclonic seizure. Tell me the causes for these things. Yes, as you mentioned, hyponatremia, hypocalcemia, hypomagnesemia, hypernatremia all can cause seizure. So answer is D. My question is, these are all the four types of seizure in newborn. Hey, no, we don't get Dharani. Please, I am talking in terms of neonate, my dear girl. I am not talking in terms of absent seizure. I am talking neonate. Most common seizure is subtle seizure like lip smacking. Okay. Most common cause is birth asphyxia. Tonic posturing. Most common in a preterm. Why it occurs? It is due to intraventricular hemorrhage. Intraventricular hemorrhage. Third one, clonic seizures. Third one is clonic seizures. So clonic seizures means it is neonatal stroke. People must be thinking that the manifestation of stroke will be hemiplegia or monoplegia. In neonate, the manifestation of clonic stroke is clonic seizures. Myoclonic seizure. This is myoclonic seizure. It is always inborn errors of metabolism. It always means inborn errors of metabolism. Since one of you told absent seizure doesn't occur in newborn period. Okay, if at all someone is doing some things with respect to you, a girl is standing. Okay, if someone doing some this kind of lip smacking movement, okay, someone does this lip smacking movement and saying that he is having a subtle seizure. He is having subtle seizure. So girls, how do you manage those boys? Very simple. You just give him a slap and tell him that you have Rolandic seizure. You have hemibalismus. Okay, because of hemibalismus, you hit him, you can say. Right? Then, okay, next question. So, I repeat subtle seizure, birth asphyxia, tonic seizure, intraventricular hemorrhage, clonic seizure, stroke, myoclonic seizure, inborn errors of metabolism. Okay, again, Monimola, I am happy, da, I am happy, da, you made my day. Da. Okay, I'll try to improve further. Okay, right. Then, okay. So, Sapna, don't forget about this hemibalismus. Okay, it will be useful for you. Okay, from which of the following antigen would hepatitis B subunit vaccine? The answer is very, very easy. Hepatitis B surface antigen. The answer is very, very B. But apart from that, I would like to stress certain points. So the vaccine that should know vaccine at birth. What are all the vaccine at birth? Come on, tell me. What are all the vaccines at birth? The vaccine at birth are OPV, BCG, and then hepatitis B. The vaccine at birth are OPV, BCG, and hepatitis B. So, a child less than 2 kgs. A child less than 2 kgs. Which vaccine you will not give? Is it a OPV, BCG, or hepatitis B? Yes, I agree with all of you. My question is the child is 1800 grams. Which vaccine you will not give? Doc Stock had answered BCG, OPV, BCG, hepatitis B. Which vaccine you will not give in newborn when it is less than 2 kgs? No, 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 no. Naman, no. Doc Stock, no. OPV can be given. BCG can be given. The answer is hepatitis B. You won't give in a child less than okay 2 kgs. So if you give hepatitis B in less than 2 kgs, that should not be considered as dose 1. That okay should not be considered as first dose. That should not be considered. You need to again start 016. You need to again start 016. So this is main thing with respect to hepatitis B. Should not be given in less than 2 kgs. You need to start the vaccine only after 2 kgs. But if the mother is hepatitis B positive, then even when the child is less than 2 kgs, it won't, the immunity will not be produced. When you give in preterm, BCG vaccine will produce the T cell mediated immunity, OPV will produce, but study says that hepatitis B is not mounting an immune response in preterm. The only indication if you want to give is children less than 2 kgs born to hepatitis B mother, you can start hepatitis B immediately after mother along with hepatitis B immunoglobulin that should be given within 12 hours. That should be given within 12 hours after birth. Okay? Right. Now, the next question. What is this? In males, what would be the most common cause for obstruction? In males, what will be the most common cause for obstruction in urine flow? Again, an answer is very, 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 very easy. Answer. Okay, so it is posterior urethral wall. Erythrocyte usually presents with urinary tract infection. I repeat, erythrocyte usually presents with urinary tract infection. We don't find the anterior urethral wall. It is usually found in posterior urethral wall. Urethral atresia, again such an uncommon condition characterized by failure to pass urine, not obstruction, failure to pass urine. Okay. And again, what will be the manifestation of posterior urethral wall? Any boy with poor urinary stream, any boy with poor urine stream, all boys should be asked for this question. Any boy with poor urinary stream, palpable bladder. I repeat, palpable bladder. Boy, palpable bladder, posterior urethral wall. The next investigation of choice is, don't say it is USG. The investigation of choice is micturating cystourethrogram to confirm your dilated urethra. To confirm your dilated posterior urethra. Okay. Confirm your dilated posterior urethra. The treatment of choice depends on this condition. If the child is stable, then you can use transurethral fulguration. Urethral fulguration. If the child is not stable, then you can't do this corrective procedure. You need to do ureterostomy. Urethra will be kept in the abdominal wall till the bladder undergoes resolution. As someone mentioned, it can also be present as chronic renal failure. An unnoticed posturethral wall can cause chronic renal failure. It is the most common cause for bilateral vesico-ureteric reflex, vesical-ureteral reflex, and it can also present with recurrent urinary tract infection. Recurrent urinary tract infection, right? Okay. Recurrent urinary tract infection, right? So this is over. Which one? Next question. This is relatively easy for my kids. Okay, right. Then, an impaired collagen synthesis in which disorder? The answer is very, very easy. What is the answer? What is the answer? Impaired collagen synthesis. Again, you know, scurvy, right? So, beriberi, what is the manifestation of a beriberi in infants? Can anyone tell me? What is the, you all know dry beriberi, wet beriberi. Dry beriberi means peripheral neuropathy. Wet beriberi means CCF. What is the manifestation of this beriberi in infants? That is thiamine deficiency in infants. Thiamine deficiency in infants. What is the manifestation? No. Is it dry beriberi producing peripheral neuropathy or wet beriberi producing congestive cardiac failure? Answer, it is infantile aphonia. The manifestation of beriberi in newborn is infantile aphonia or loss of voice. Aphonia or loss of voice. Rickets, you all know that less than 6 months is usually either VDDR rickets type 1 or VDDR rickets type 2, less than 6 months. Whereas more than 6 months to 2 years is usually the manifestation of nutritional rickets. Manifestation of nutritional rickets. And finally, when the manifestation is after 2 years, it is usually X-linked hypophosphatemic rickets. X-linked hypophosphatemic rickets. X-linked hypophosphatemic rickets. Right? So again, so many questions can be asked based on rickets. Let me make it very, very fast. So what is the investigation of choice? Let me write some case scenarios. With reduced to 25 OHD3. Okay, one question number one. Question number two, reduced 125 OHD3. Question number three, increased 125 OHD3. Question number three. You tell me what is the answer for these three things. Case scenario 1, 2, 3. Okay. Next case scenario. Your parathyroid hormone is normal but phosphorus is low. What is this condition? And the next scenario is PTH is high, phosphorus is high. So what is this condition? You tell me the answer. Rickets. Yeah. Can you please, Naman? Yeah, I'm going to explain to you, my dear, again. So when you have reduced to 25 hydroxy D3, it is nutritional rickets. It is nutritional rickets. Okay, when you have reduced to 125 dihydroxy D3 means 1 alpha hydroxylase is absent. So this is VDDR type 1. Type 1. When this 125 dihydroxy D3 has got resistance, then 125 dihydroxy D3 will be high. So will be very high. So high 125 dihydroxy D3 is VDDR type 2. Type 2. Again, the only in all these cases, I repeat, in all these cases, remember in case 1, case 2, case 3, in all these cases, parathyroid hormone will be high. Very, very important. Parathyroid hormone will be very, very high. Phosphorus will be very, very low. Very, very simple. Very, very simple. So you can consider this as a combination. When you have a hypophosphatemia along with the hyperparathyroidism, look for 125 OHD3 low nutritional rickets, 125 low VDDR type 1, 125 high VDDR type 2. Very simple. The only place where you can get this combination of normal parathyroid hormone with the low phosphorus. Remember, remember this is the place where you need to suspect X-linked hypophosphatemic rickets. The only rickets in which parathyroid hormone levels are normal, I repeat, Naman, the only place where you find the parathyroid hormone levels are normal is I repeat, the only time you find the parathyroid hormone levels are normal is hypophosphatemic rickets. Then you can ask me why parathyroid hormone is not elevated. Parathyroid hormone is always concerned with respect to hypocalcemia. He is a biased fellow. He never ever bothers about hypophosphatemia. That's why in the first three conditions, hypocalcemia occurs, but in an X-linked hypophosphatemic rickets, calcium remains normal, phosphorus is low. That's why your parathyroid hormone levels are normal. I repeat, the deadly combination of a normal parathyroid hormone with the low phosphorus occurs only in X-linked hypophosphatemic rickets. And finally, when you have high phosphorus and high phosphorus and high parathyroid hormone, the only condition you will find is chronic renal failure. I bet the only condition you will find out is chronic renal failure. Remember, my dear friends, with this 5 scenarios, you will get definitely one question correct. I repeat, you will be definitely getting a permutation and combination of this. So instead of getting confused with yourself with so many things, do not look into calcium. I repeat, in any cases of rickets, do not look into calcium. Just look into parathyroid, just look into phosphorus. Then you can ask me, sir, PTH is normal hypophosphatemic, PTH is high, phosphorus is high, CRF, but in the first three conditions both phosphorus is low and parathyroid is high. How can I distinguish? The answer is very simple. The nutritional rickets always, I repeat, the nutritional rickets always the onset after than 6 months, whereas this type 1 and type 2, the rickets onset less than 6 months. Very, very easy. Second point, then you can ask, based on the scenario, is it possible to differentiate between VDDR type 1 and type 2? Because both are associated with hypophosphatemia, both are associated with hyperparathyroidism, both are associated with less than 6 months. Then the simple clue is presence of alopecia. Then the simple clue is presence of alopecia. Whenever you have a alopecia, it is in favor of VDDR type 2. Alopecia indicates VDDR type 2. Again, the last but not least, rickets with dental abscess, rickets with dental abscess along with predominant lower limb involvement, along predominant lower limb involvement is again, I repeat, X-linked hypophosphatemic rickets. So what is the treatment for X-linked hypophosphatemic rickets? What is the treatment for X-linked hypophosphatemic rickets? What is that? I am waiting for your answer. What is that monoclonal antibody for FGF, fibroblast growth factor 23? What is that answer? Waiting for you to answer. It is burozimab. Zumab. So again, one more point. What is the best time to get sunlight? What is the best time to get sunlight? The best time to get sunlight is, don't say early morning, early night. It is 11 a.m. to 3 p.m. The best time to get sunlight and vitamin D is 11 a.m. to 3 p.m. Another MCQ. Okay, 11 a.m. to 3 p.m. Right? So STARS regimen is not followed now. STARS regimen, we don't follow STARS regimen. What is STARS regimen? Giving 6 lakh international units. Okay, single dose IM is not followed now. Now what we follow is less than 2 years, more than 2 years. Less than 2 years means you give 2000 international units. You give 2000 international units per day into 3 months or 12 weeks. More than 2 years means 3000 international units per day into 3 months. Can you tell me what is the radiological sign of recovery of rickets? I am asking you radiological sign of recovery of rickets. It is otherwise called as zone of provisional calcification. Zone of provisional calcification. After 4 weeks of treatment with white line. Someone right. I I was expecting you to answer white line of wrinkle. White line. No, 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 no. Please stop. Stop. Never ever use the word white line. It is scurvy. White line of wrinkle leads to scurvy. I was expecting you to answer this. You are answered. No, my dear boy. It is called zone of provisional calcification. It is white in color. Plus, please do not mention as wrinkle. Zone of line of wrinkle usually presents in vitamin C deficiency. Here, zone of provisional calcification at the area of epiphysis. Okay, please again, after hearing that docs as mentioned wrinkle, it is not wrinkle, not wrinkle. Please correct yourself. Wrinkle occurs in curvy. Just say, again, just say zone of provisional calcification. Please type and post. Then only my kids will not forget. Please type and post. NASA Edge, I am not speaking about the radiological feature of rickets. I was talking about the radiological recovery of rickets. Okay, please post. At least 2 or 3 I need to say zone of provisional calcification in your chat box. Then only I will move to the next question. Right. Okay, Tarani. Zone of provisional calcification. Right. Peripheral calcification. Docs, what happened, right? It is not peripheral calcification. Zone of provisional calcification. Okay, I'm happy. Leave it. Okay. Right. In a child, which among the following will be most effective in treatment of COVID-19 infection? That's it. My kids definitely will not do mistake with respect to scurvy or a response to vitamin D therapy. Okay. So, what are all the treatment options available, my dear boys and girls, with respect to COVID? The treatment options are: one is steroids, another one is remdesivir, another one is enoxaparin, another one is enoxaparin. Remdesivir is so mild, moderate, severe. In mild case, steroid. In moderate, steroid plus remdesivir. In severe case, enoxaparin. So this can be DEXA. That steroid can be DEXA or it can be pulse MPS. Or it can be pulse MPS. So the treatment of choice is steroids. Now I am going to ask my kids. This is, I have not personally seen children suffering from COVID due to the direct involvement of respiratory tract infection. Now tell me, what is the manifestation of COVID in children? I am expecting your answer. Manifestation of COVID in children. I am waiting for your answer. I am starting writing something. What is that name called as? What is that name? RD means, what is that, Dharani? What do you mean by RD? Recurrent deposit? That the doctors cannot going to see. No, what happened, my dear kids? Manifestation of COVID in children. That's it, Nico. That's it, my dear boy. That's it. MISC. Very good, Nico. It's MISC. So what is that? What is that? So it is, what is that MISC, my dear boy? So MISC means, so before that let me complete. Any child between 0 to 19 years with fever of more than 3 days, with fever of more than 3 days, with any of these manifestation. What are all the manifestation? CCF or Kawasaki disease like syndrome, or they can present with the shock, or they can present with coagulopathy, or they can present with prolonged fever, or they can present with abdominal pain, appendicitis like picture, and then you can have PT can be elevated, PTT can be elevated, dimer can be elevated. So it is, and COVID serology will be positive. COVID serology will be positive instead of COVID. So what is this? This is called, as someone mentioned, multi-system inflammatory disease. Multi-system inflammatory disease or syndrome. C stands for COVID. Multi-system inflammatory disease associated with COVID-19. This is called MISC. Multi-system involvement associated with COVID, nothing but a cytokine storm. So what is this? This is nothing but a cytokine storm, mainly due to interleukin 1, interleukin 6. That's all. It is a cytokine storm. Treatment is steroids, IVIG, Anakinra. What is Anakinra? Interleukin 1 antagonist, or it rarely we use rituximab. Okay, they produce three types of manifestation. One is, okay, they produce Kawasaki like disease. They produce Kawasaki like disease, or they can manifest with the shock like status, or they can manifest with only fever, febrile syndrome. Okay, that's all. That's all. So please remember, my dear boys and girls, whenever you get a history of exposure to prior history of COVID and any of the children presenting with these manifestations, think in terms of MISC rather than Kawasaki. So important clue means, in Kawasaki disease, platelet will be very, 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 very high. You will get thrombocytosis, whereas in MISC, your platelet will be low, thrombocytopenia. This is the important difference between Kawasaki disease and MISC. And remember, they are also prone to produce coronary artery aneurysm. They are also prone to produce coronary artery aneurysm. So, which one? MISC, multi-system inflammatory response syndrome associated with COVID. That's it. Okay, next one. Which of the following vaccine is associated with intussusception? Such an easy question. Associated with intussusception. So you all know the vaccine that is associated with intussusception is rotavirus vaccine. Associated with intussusception is rotavirus vaccine. So just leave it. Okay, so just have to have a complete. When will you give rotavirus vaccine? Rotavirus vaccine is usually given at, Rota is usually given at 6 weeks, 10 weeks, 14 weeks. When will you give MR? MR1 at 9 to 12 months and MR2 at 15 to 18 months. Okay. What is the vaccine that you give at 5 years? Answer. And what is the vaccine that you give at 10 years? What is the vaccine that you give at 5 years and what is the vaccine that you give at 10 years? Answer. Vaccine at 5 years and vaccine at 10 years. Come on, answer, my dear boy. Vaccine at 10 years and vaccine at 5 years. Waiting for your answer. Caps and small letters are very, very important. When you write small letter, it means low antigenicity. So don't do that mistake. 5 years, capital D, capital P, capital T. 5 years. At 10 years, capital T, small d. Narani, you are correct. The problem with the ducks and the Sindhu, small d, small p, small t. Problem with the Naman, both small. So Naman, it is capital T, small d. Ducks Sindhu, it is capital T, capital P, capital T. So it is DPT, it is TD. When will you give HPV vaccine, my dear boys and girls? HPV vaccine, because but many centers HPV vaccine has been introduced. Even Tamil Nadu has introduced HPV vaccine. Answer: HPV vaccine. Age group, how many doses? Age group, how many doses? Age group, how many doses? 9 to 21 wrong. Dogs 14 okay. When to when? Wrong. Nico wrong. Naman wrong. 1 month, 3 month wrong. Sudhir Panda wrong. Sidhu wrong. Dogs correct. 2 doses, dogs correct. It is 2 doses. I am a pediatrician now. 2 doses, 9 years to 14 years. 2 doses, 9 years to 14 years. Yes, Naman told 0 and 6. This is the government schedule. I am not talking about adults. Government schedule 0, 9 years to 14 years, 2 doses at 0 months and 6 months. HPV vaccine. Okay, right. Tell me what are all the vaccines that are given at the 9th month? What are all the vaccines given at the 9th month? As far as questions are concerned, always it is national immunization schedule. As far as questions are concerned, national immunization schedule, NASA. This is national immunization schedule. What are all the vaccines given at 9 months? Still to get the complete answer. Still to get the complete answer. Hindu, Aki, Niku, Tarni. Wrong. Wrong. Incomplete. John. Correct. John, correct. Okay. At 9 months, JE1, MR1, OPV. This all of you know. But for the past 2 years, vitamin A, yes, I agree. Don't, John, never ever write measles alone. Rubella has been included. Apart from that, IPV booster, PCV booster, IPV booster intradermal at 9 months, PCV booster intramuscular at 9 months. Only John had answered, rest of them you not answered. Okay, so don't say 3 pa. Nishita, you had answered IPV3, PCV3. It is not third dose, it is booster dose. First dose. So, intradermal IPV, dose 1, dose 2, booster. So, dose 1, dose 2, booster. Intradermal IPV, dose 1, 6 weeks, dose 2, 14 weeks, booster 9 months. Same way, PCV1, 6 weeks, PCV2, 14 weeks, and PCV booster is 9 months. Okay, baby? PCV booster is 9 months. Don't make a mistake, my dear boy. Okay? Right. Next. In juvenile dermatosis, the most typical manifestation would be answer is easy. Answer. Okay. Answer is easy. Okay. So malar rash is a manifestation of SLE. Gotron papule, where it comes, my dear boy? Where does Gotron papules comes? Where does Gotron papule comes? Gotron papule in knuckles. Okay. Heliotrope rash. Heliotrope rash. Upper eyelid. Say upper eyelid with edema. Upper eyelid. Upper eyelid with edema. Photosensitivity is a manifestation of dermatomyositis. Yes or no? Schonlein. Agree, dear. Photosensitivity is a manifestation of dermatomyositis. Say yes or no? Photosensitivity is a manifestation of SLE. All of you know. Is photosensitivity is a manifestation of dermatomyositis? Yes or no? Waiting for your answer. No. Tarani said no. Others. Abhi, Niku, NASA, Sindhu. Photosensitivity is a manifestation of JDM. Yes, no. The answer is, the answer is, the answer is, the answer is, John and Sindhu are correct. Yes, yes, yes. Photosensitivity is a manifestation of, right. Next point, periungual telangiectasia will come. Say yes or no. Periungual telangiectasia in dermatomyositis, yes or no. The question is, most typical manifestation is Gotron papule and heliotrope rash. No one has got the confusion. Photosensitivity will come, but not diagnostic. Periungual telangiectasia, yes or no? Periungual telangiectasia, yes or no? Yes. It is called nail fold capillary dropouts. It is called nail fold capillary dropouts. It is detected at nail bed through ophthalmoscopy. Very, very important. Even though we don't test, it is there. John, it is there. Periungo, it is nail fold capillary dropouts. Another question. What is the antibody in most common antibody in JDM? Anyone? What are you eating, sir? I feel hungry, man. I'm 48-year-old now. Has been taking class without any break for the past 2.5 hours. Sorry, 1.5 hours. Docs is concentrating on this man. Look at this kids. Okay. What is the anti-Jo? Nishi, correct. Anti-Jo is specific. Nishta has mentioned anti-Jo. It is specific. But what is the most common? MI2, Sindhu, correct. MI2, you are correct. Anti-Jo is correct. MI2 is correct. Anti-Jo is correct. MI2 is correct. But the question is, what is the most common? Wait, anti-Jo correct. MI2 correct. What is the most common? Mission Impossible 2 nahi hai. ANA. Anti-nuclear antibody is present in 95% of K. Very good, Tarani. Okay, wa? Anti-nuclear antibody. Anti-nuclear antibody is present in 95% of cases of juvenile dermatomyositis. Next question. What is the recent? You all know you can detect with the help of CPK. You can detect with the help of EMG. You can detect with the help of biopsy. You can help with the detect of lactate dehydrogenase enzyme elevation. Okay. The question is, what is the most common? ANA is most common. Sensitive and specific is JO. It is there in OP guide itself. No need to go for your Harrison. It is there. Okay. Now, what is this? But what is the investigation of choice in a child with, let me say, PUO plus Gover sign positive, PUO plus Gover sign positive with elevated CPK? with the Gotran papule. What is the next investigation of choice? NASA, tell me, dear. A child is brought with PUO, Coversign is positive, elevated CPK, Gotran papule is present. What next? What next? Tarani has answered EMG. This is again very. So one has answered EMG. The next one has answered muscle biopsy. Recent concept. NASA, you tell me, my dear boy from Harrison. Kausi, biopsy. Sindhu, biopsy. Non-invasive. It has become non-invasive. Whenever you have a child with PUO, with Goversign, with elevated CPK and Gotran papule, invariably it is juvenile dermatomyositis. What next? What next, Aki? BX means what? LDH? No, they are all indirect. NASA, is there anything you have read in Harrison Ma? Tell me, dear. Let me wait what NASA is searching in Harrison. Shall I write? I am going to write the answer. The recent non-invasive investigation of choice in a typical suspected juvenile dermatomyositis is dash. MRI thigh. Very simple. MRI thigh. In MRI, in two T2 weighted images, you will find hyperintense signals. In T1 weighted images, you will see fibrofatty replacement. So the answer is, I repeat, my dear boys and girls, the investigation, non-invasive investigation of choice in a suspected with the typical presentation is MRI thigh. I want you to post this word in our chat box. And until then, I will be waiting for the next question to start. Answer. Come on. MRI thigh is the non-invasive investigation of choice. At least one of you should type and post in chat box. MRI thigh, because no one of you had answered. Please go for it. Right, done. John, done. Okay. Right. Okay. Very good, my dear. Okay, then in the age group of 1 to 14, 4 years, the decreasing order of cause of death is one is pneumonia, followed by diarrhea, followed by injury, then malaria. So let me write pneumonia, diarrhea, injury, followed by malaria. Literally, we don't see any malaria at present. Okay, my dear boy. Okay, my dear boy. Now let me complete within one slide. I am going to complete ARI control program. And you are going to tell me the answer. Respiratory rate, chest in drawing, red flags, or general danger sign. So for the first case, nothing is there. For the second case, rate is good, rate is high compared to the age. Chest in drawing nahi hai, danger signs nahi hai. For the third case, rate is good, chest in drawing is there but no red flag. For the next case, all of them are there. So case A, case B, case C, case D. So now you tell me, what is the treatment of choice? You got malaria recently, then you must belong to the seashore area, or you must belong to northeastern area. Yes or no? Right. Literally in Tamil Nadu, I had not seen, even in South India, I had not seen any malaria cases are reported so far. Okay. A at home. Very good. It is no pneumonia. It is no pneumonia. It is usually in northeast place. Okay. Right. So for the next, where falciparum is more common compared to malaria. Second, only rate is good. So this is called fast breathing pneumonia. The second one is called chest indrawing. Third one is called Chest drying pneumonia. Fourth one is pneumonia with danger signs. Pneumonia with danger signs. Now you tell me. Now you tell me what is the. So I have four. One is no pneumonia. Another is fast breathing pneumonia. Another is chest drying pneumonia. Another is pneumonia with danger signs. Now my question is, home management is indicated in A, B, C, D. Answer. Home management is indicated in A, B, C, D. Naman, A, B. Home management is indicated in case A, case B, case C, case D. Waiting for your answer. Let me wait for 15 more seconds. Niku, AB. Kalps, AB. Our RRR, AB. Tarani, ABC. Yes, my dear friends, I need to appreciate our docs. Remember, the main difference between old guidelines and new guidelines is this one. No pneumonia, no need for any admission. Fast breathing pneumonia, no need for any admission. The new thing is, even pneumonia with the chest drying can be managed with the home. So the answer is A, B, C. Doc has answered. Tharani has answered. A majority of you have voted only for A and B. So remember, my dear friends, pneumonia with the chest drying can be managed at home. I repeat, pneumonia with the chest drying can be managed at home. That's why A comes under no pneumonia. B and C comes under non-severe pneumonia. I repeat, B and C comes under non-severe pneumonia. The only indication to admit is pneumonia with danger signs. You need an IP. So I repeat, those who had made mistake in this, please type and post. Children with chest drying can be managed at home. Come on. Children with chest drying can be managed at home. This is the difference. That's why both fast breathing pneumonia and the chest drying pneumonia comes under non-severe pneumonia. Comes under non-severe pneumonia. Pneumonia with the danger signs alone you can need to admit. So what is the drug of choice? What is the drug of choice? No drugs. For fast breathing pneumonia, amoxicillin. For chest drying pneumonia, amoxicillin. What is the WHO management? 80 mg per kg in 2 divided doses. 80 mg plus yes culps, yes Niku. Don't make mistake, Naman 2. Okay? Right. So, for fast breathing pneumonia and fast breathing pneumonia, amoxicillin 80 mg per kg per day. Since you are decided both of them should be treated with oral. For chest drying pneumonia also amoxicillin 80 mg per kg per day. But what is the difference? For fast breathing pneumonia 3 days, whereas chest drying pneumonia 5 days. Chest drying pneumonia 5 days. Amoxicillin 80 mg per kg per day. Again, there is no role for cotrimoxazole. Never ever write cotrimoxazole hereafter. Pneumonia with the danger signs. Pneumonia with the danger signs, ampicillin and then gentamicin. Ampicillin 200 mg per kg per day. Gentamicin 7.5 mg per kg per day, both for 7 days. But when you are in a PHC, start Ampi Genta and then refer. If Ampi is not available, start Amox Genta and refer. That's it. That's it. So this is how no role for cotrimoxazole. Please do not write. Why, man? Why? Previously we have. So what are all the new things in IMNCA guidelines? Come on, docs. What are all the new things? So new things that my kids learned today, new things in ARI control program. So question number 1, no role for cotrimoxazole, because majority of them streptococcus pneumoniae, they won't respond to your cotrimoxazole. Second point, amoxicillin at a higher doses. Amoxicillin at higher doses of 80 mg per kg per. Second thing you learn. Third thing, what you learned? Chest-in drawing can be managed at home. Chest-in drawing can be managed at home. Third thing you learned, my kids learned. Fourth thing, what my kids learn, SpO2 is incorporated in IMNCI, and SpO2 of less than 90%, refer the case. Refer the case. Okay, fourth point. Fifth point, SpO2 of less than 90%, refer the case. If you find V's, no antibiotics. If you find V's on auscultation, no antibiotic. Instead, short-acting beta agonist SABA. SABA is not Sarath Balaji, my dear. Short-acting beta 2 agonist, that is your salbutamol. Sixth one, if cough more than 2 weeks, rule out two things. One is TB, another is asthma. So this is the new adaptation of IMNCA, Indian adaptation of IMNCA, Indian adaptation. Okay, baby? IMNCA, Indian adaptation of ARI control program. Very, very important 6 points. Okay. So like triple R, forget all old things and reset your points with respect to IMNCA with this. Okay, 6 points. Okay, baby? Right. Hey, this handwriting okay, Nada? If he is able to understand, just leave me. Okay, right. Okay, then what is this? Repeat point number 5. What my child is saying. When see previously there is no mention on these. Whenever any child is brought with tachypnea, start antibiotic. But right now, auscultation reveals wheels means don't give any antibiotic. Instead, give short-acting beta-2 agonist salbutamol. Salbutamol. Okay. Valid, write in Tamil, sir. Already I am writing in Tamil only, man. Okay, right. Okay, this fellow, na. Okay, right. I know, I know. You are marking my handwriting. I am writing in Tanglish. People used to speak in Tanglish. You are saying I am writing in Tanglish. Ah? Okay, da. Okay, malaria fellow. All because of that malarial parasite in you. Okay, this makes you to speak that. Okay, I am from Chennai, my dear dogs. Okay, right. Okay, I don't think this you need to give much importance. The most common cause for the most common cause for neonatal mortality. I don't want to waste much time. One is preterm, second one is sepsis, preterm, second one is sepsis, third one is birth asphyxia, fourth one is congenital anomalies. Fourth one is congenital anomalies. I don't want to give much importance to this. Let me teach you some other thing to my kids. Right. Then in a 3-year-old child, there was a palatable abdominal mass and there was also a history of hematuria which resolved after 2 days. Which among the following investigation to be done? Whichever following investigation to be done? What is the diagnosis? What is the investigation? D. Diagnosis. Diagnosis. M. Renal mass. Right, any abnormal thing is renal mass. Palatable abnormal thing is renal mass, abdominal. Let me ask you one question. Here comes the wrong answer that I was expecting from 1 month Sapna. Here comes the wrong answer. So, so, 1 second. Most common in our one-liners, dots correct. Most common neonatal abdominal mass. Question number 1. Question number 2. Most common mass less than 3 months. Most common mass 3 months to 1 year. You must not be expecting this question now. Most common mass between 1 to 5 years. And most common mass between 5 about 12 years or adolescent. Answer, come on, fatafat. 1, 2, 3, 4, 5. You need to mention and answer me. 1, 2, 3, 4, 5. Most common neonatal abdominal mass. Compared to, I appreciate you, but compared to it is multicystic dysplastic kidney. It is multicystic dysplastic kidney. Most common less than 3 years renal mass is, first is multicystic dysplastic kidney. Most common less than 3 months is mesonephric blastema. That is called as what? Mesonephric blastema. Most common renal tumor. Pasangala, I'm speaking about renal tumor. Most common renal tumor between 3 months to 1 year is neuroblastoma. Most common 1 to 5 years is Wilms tumor. Apart from neuroblastoma doesn't arise from kidney. Instead, there is a small correction, my dear boy. It is rhabdoid tumor. Most common 3 months to 1 year is rhabdoid tumor. By about 12 years, you get your renal cell carcinoma. And 1 to 5 years, apart from Wilms tumor, you have clear cell sarcoma. Then you must be wondering, sir, what about neuroblastoma? Neuroblastoma is the most common abdominal mass in infancy. Abdominal mass. It doesn't arise from renal. It arises from suprarenal. Most common abdominal mass in infancy is neuroblastoma. But when someone is asking about renal tumor or renal mass, neonatal is multicystic dysplastic kidney. Less than 3 months, mesonephric blastoma. 3 months to 1 year, rhabdoid tumor. 1 to 5 years, Wilms tumor. Or clear cell sarcoma. By about only 12 years, you get renal cell carcinoma. Remember, most common abdominal mass in infancy is neuroblastoma. Most common neonatal abdominal mass is multicystic dysplastic kidney. Okay, baby, is it okay? Because so many of you get confused with these things. Okay, shall I proceed to the next? Clear cell sarcoma. Sindhu, it's clear cell sarcoma. Clear cell sarcoma. Right. Okay, done. Let again, very important. Okay. So now the question is, now any child with asymptomatic abdominal mass is Wilms tumor unless otherwise proved. Come on, tell me from your place, wherever you are. Any child with the asymptomatic abdominal mass is Wilms tumor unless otherwise proved. Okay, right. What are all the other manifestation? That hematuria are all very less. That hematuria is all very less. Okay. Apart from that, Apart from that, what is 11p13? What is 11p13? What is 11p15 mutation? What is 11p13 and 11p15 mutation? 11p is Vagar syndrome. That is Wilms tumor, aniridia, genital growth and renal anomalies. Vagar syndrome. 11p is Beckwith-Wiedemann syndrome. 11p is 11p 13 deletion is Vagar syndrome. 11p 15 deletion is Beckwith-Wiedemann syndrome. And what is this? Steroid resistant nephrotic syndrome along with the male ambiguous genitalia. What is this? Male ambiguous genitalia. What is this condition? Male ambiguous genitalia. What is this condition? This is called Dennis-Drash. This is called Dennis-Drash syndrome. These three are bilateral Wilms tumor. These three are bilateral Wilms tumor. Very good, marrow. The investigation of choice for any renal mass is contrast enhanced CT abdomen. Contrast enhanced CT abdomen. And one more beautiful point. If you find calcification, it is usually neuroblastoma. If you find no calcification, it is usually Wilms tumor. Again, I am going to ask two pathology questions. What is the histopathology of Wilms tumor? One more question. What is called stage 5 Wilms tumor? What is called stage 5 Wilms tumor? Very good, Nico. You are correct. Neuroblastoma crosses, this won't cross. My question is, what is the histopathological? I am extremely sorry. Small round blue cell tumors nahi hai. No. Be precise. No. No. Be precise. Be precise. That's it. That's it. Docs. Triphasic blastema. Whenever someone says about Wilms tumor, it is triphasic blastema. Stromal, epithelial, tubular component, all. Please write it down. Those who made a mistake, epithelial, very good docs. Those who made a mistake, please type and post. Triphasic blastema is the histopathological feature of Wilms tumor. Come on, post it. You made a mistake. Okay. Triphasic blastema. Second, and what is stage 5? Someone had posted. I love it. It is bilateral Wilms is stage 5. Opposite site involvement is stage 5. Okay. Now the question is to all my children who had completed pathology, Wilms tumor comes under sarcoma, teratoma, carcinoma. Answer. Wilms tumor comes under sarcoma, teratoma, carcinoma. Answer. Or D, none of the above. D, none of the above. Tharani opted for sarcoma. Docs. Come on. Wilms tumor comes under sarcoma, teratoma, carcinoid. None of the above. Sapna opts for carcinoma. Marrow, none. So what is the answer? It comes under what tumor? Pathology. Classification of tumor. My dear boys and girls, what does it come under then? It belongs to mixed tumor. No, Abhi, it is not teratoma. Mixed tumor means two germ layer. Mixed tumor along with pleomorphic adenoma of parotid. Pleomorphic adenoma of parotid. It is not teratoma. Then what is the difference between mixed tumor and the teratoma? Teratoma, many cells, many germ layers, more than one germ layer, ectoderm, endoderm, mesoderm. Whereas mixed tumor means many cell types but one germ layer. That is the difference between mixed tumor and teratoma. Okay, baby? The difference between mixed tumor is it arises from one germ layer but contain many cells. But your teratoma is many cells, many germ layers. Okay, Neha? Okay. Listening with good ears. Come on. Okay. Okay, baby? Right. Is it new or somewhat you are misleaded before? This is new thing, na? I think you must be clear right now. All my kids are clear right now with the difference between mixed tumor and teratoma, isn't it, baby? Okay, right. Okay, which of the following are the components of pentavalent vaccine? A Jujupi question for my kids. So it is DPT, tetanus, Hib, and hepatitis B. Leave it. I am not going to explain in detail. Okay, under kangaroo mother care, which of the following components are included? Answer. Don't ask me this. This is water. Okay. Very, very simple. It is skin to skin contact, exclusive breastfeeding, and yearly discharge from the hospital. Remember, two more. Who invented it? It is invented by a male called Edgar Ray. This can be followed after 1800 grams. In the child attains 1800 grams, you can follow. Even before that, also you can start. And remember, each session a minimum of more than 1 hour of skin to skin contact. A minimum of more than 1 hour. Okay, should be there. Which one? Kangaroo mother cat. Right. Now comes, I don't know whether it is a tough question, easy question, a biochemistry question, or physiology question. In physiological jaundice, which among the following is correct? Before KMC, you can do. Usually starts after 1800 grams. Usually after 1800 grams. In case of twins, even when it is lower, if then Marrow has asked me one question. Can it be possible before 1800 grand? The answer is yes. If they are hemodynamically stable, you can start, my dear boy. Hemodynamically stable, you can start. So, is this tough or easy? Physiological jaundice, among which of the following is correct? It is characterized by increased indirect bilirubin. Indirect bilirubin is not excreted in urine. So decreased urine bilirubin. But this bilirubin, what will happen? It will be converted into urobilinogen and excreted in urine. So the answer is D. The answer is D. So don't get carried away by this question. This is such a beautiful question. Very, very simple, but really a very good question. Increased indirect bilirubin, which will not be excreted urine. So, urine bilirubin is low, but this hemolytic jaundice leading to increased urobilinogen production in the intestine, absorbed enterohepatic circulation and excreted in urine. Right, D answer. In congenital hypertrophic pyloric stenosis, unstable child, what is the drug of choice? Wait, my dear boys and girls. The question is The question is urine urobilinogen. Whether it is there or not, urine urobilinogen in hemolytic jaundice will be increased. More and more bilirubin will be excreted in the urine, so it will be increased. Present as well as increased. So my question is, what is the, I am not asking what is the treatment. I am not asking what is the treatment. What is the drug of choice for infantile hypertrophic pyloric stenosis? I am not asking this, boss. I am not asking what is the drug of choice for infantile hypertrophic pyloric stenosis. Marrow, I am not asking treatment of choice. I am asking drug of choice. The answer is, the answer is atropine. Unstable, unstable. Yes, Nico. Go and read. Go and read, Nico. You all know your anticholinergics are antisphincteric in action. It relaxes sphincter. Atropine is the drug of choice. It relaxes pyloric sphincter. Go and read. This is the new thing for my kids. In unstable children with infantile hypertrophic pyloric stenosis, even in side by side, you can refer in your other mobile or iPad. Atropine is the drug of choice because all other things my kids know. All other things my kids know. That's why I want to offer something new to my kids. Atropine is the drug of choice for infantile hypertrophic pyloric stenosis. Rest, it is non-bilious vomiting. Yes, it is palpable mass, palpable ovoid mass. It is not right to left, it is left to right. Hypokalemic, yes, the answer is yes. Metabolic alkalosis, the answer is yes. Okay, baby. So never forget, those who are attending here, there are very high chances for you to get this question. Unstable hypertrophic pyloric stenosis is atropine. Okay? Right. The rest you know, ma. This is such a simple question. In a 12-year-old child, there was a selective autism. What is the most likely cause? Basically, this is a question of psychiatry. Answer, selective mutism. Selective mutism means even in my clinic, I have 4 such children. I have 4 such children. Do you believe all of them are 14 to 18 years? All of them are 14 to 18 years. They never ever talk to me. I have been seeing this for I have been seeing them for the past 7 years. Absolutely talking normal at home, but they when they come to outside, not even in school, because of absolute sheer anxiety, they will develop selective mutism. Right? Okay, next. Which among the following statement is correct about steroid dependent nephrotic syndrome with respect to vaccine? Again, I am going to offer some new thing to you. Get ready. Okay. Okay. B. But let me tell you. The child is on 2 mg per kg per day of prednisolone for more than 2 weeks. When will you put vaccine? The child is on 2 mg per kg per day less than 2 weeks. When will you vaccine? 3. The child is on alternative day vaccine. Sorry, alternative day prednisolone. I am sorry. Alternative day prednisolone. When will you vaccinate the child? The child who had received cyclophosphamide The child who had received cyclosporin, the child who had received rituximab, because these are all the drugs used in steroid dependent nephrotic syndrome. Answer? Answer. So when you vaccinate 2 when you give 2 mg per kg per day of prednisolone for more than 2 weeks, wait for next 4 weeks. Wait for next 4 weeks. So 2 twos are 4. When you give 2 mg per kg for more than 2 weeks, don't give vaccination for next 4 weeks. 1. When you give more less than 2 mg per kg, when you give 2 mg per kg less than 2 weeks, okay, stop and start vaccine. Stop vaccine can be started immediately when you stop your prednisolone. Alternative to prednisolone, you can put vaccine even when the child is on steroids. Even when the child is on steroids. Even when the child is on steroids. Okay. I'll explain you, Maro. Wait. No such indications. You can give, nothing will happen except that you need to make sure that whether it is a live or killed, this duration should be maintained, my dear Marrow. Cyclophosphamide 3 months after stopping cyclophosphamide. Cyclosporin 1 month after stopping cyclosporin, whether it is a mycophenolate mofetil or cyclosporin. Rituximab 6 months to 1 year. Rituximab 6 months to 1 year. Rituximab 6 months to 1 year. Okay, this is very important. Okay, baby, because often they are giving so much of importance to vaccination in nephrotic syndrome. Remember, all age related vaccines can be given. Pneumococcal vaccine, okay, all vaccinations can be given provided all vaccinations can be given. This is Indian Society of Nephrology guidelines. Okay, Indian Society of Nephrology guidelines. Okay, not during steroid, my dear boy, not during steroid. Remember, it is clearly mentioned when they take 2 mg per kg, wait for 4 weeks, then give. When he is taking less than 2 weeks, stop and start. Alternative day steroids is not going to produce any immunosuppression. That's why vaccine can be started even when the child is on steroids. Okay, this is deferred. Yes, Xavier. So defer vaccine for the 4 weeks. Stop and start can be given 3 months, 1 month, 6 months to 1 year. Okay, right. So all given all vaccines according to the schedule, but make sure how long you are going to defer the vaccine. Anyway, you can start. Okay, right. Next. This is such a beautiful question. What is this question? What is this question? Tigas Devi, right. What is this question? I will be waiting for your answer. In a 10-year-old child, there was a history of dribbling of urine, but the voiding pattern was found to be normal. What is the most probable diagnosis? What does it mean? They can pass normally as well as they will pass without their knowledge. Erythrocyl, as I told you already, the manifestation is UTI. Grade 4 UR UTI. Megaureter UTI. Whereas the question is dribbling of urine. Dribbling of urine is suggestive of ectopic urine. Dribbling of urine is suggestive of ectopic urine. Okay? No, it is not urethrocyl. The answer is ectopic urethral orifice. Ureter is ending into the urethra. That is the answer. Okay, answer is C, 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 C. Okay, ending, not origin. Ectopic orifice. Okay, answer is C. That's it, JV. That's it. Because you have external urethral sphincter, internal urethral sphincter. Ectopic ureter usually ends beyond the internal urethral sphincter, as a result of which you will get dribbling. Okay, right. So what is this? The following X-ray found in pediatric case. What is the treatment of choice for this condition, and what is this? Don't tell me what is the treatment of this condition. Tell me what is the diagnosis. What is the diagnosis? Aaron. No, 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 no. It is not Aaron. It is osteolytic skull defect. It is osteolytic skull defect. So remember, remember, my dear boy, whenever you have, whenever you have non-healing seborrhea, no spike, nothing, no, 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 stop it. It is osteolytic punched out defect. It is lytic punched out defect. It is lytic punched out defect. So it is lytic punched out defect. Whenever you have seborrhea around here, a non-healing seborrhea around here, non-healing seborrhea around your ear. One. Second one is ear discharge. Two. Third one, polyuria. Can you tell me why polyuria, my dear boys and girls? Polyuria. Can you tell me why polyuria? Why polyuria? Can you tell me? Tell me why polyuria. Answer me 1 second. Why polyuria, my dear boy? Waiting for your answer. Why polyuria? The clue is, what is this? Don't say it is hematopoietic stem cell transplant. It is nothing but, why polyuria? What is that ADH enhancement? I don't get you, Devi. The most common cause for destruction of arginine vasopressin secreting neuron is LCH. What is this? Very good. Nico, it is diabetes insipidus. What is HST? This is called as, what is that HST? Hand Sculler Christian triad. That's it. So what is the triad? Once you have osteolytic lesions. Second, you have bilateral exophthalmos. Third one is third one is diabetes, neurogenic diabetes insipidus. That's it. Neurogenic diabetes insipidus. Okay. Many of you answered it is vincristin. No, my dear, it is vinblastin. It is not vincristin. Vinblastin more than vincristin. Again, you had made a mistake. It is not vincristin. It is vinblastin. Okay. Now, what is tell me what is the specific marker for LCH? What is the light microscopic feature of LCH? Specific marker for LCH and light microscopic marker of LCH. Specific marker is CD207, that is Langerin. This is specific. Sensitive is CD1A. CD1A is sensitive. S100 again, now again S100 screening, CD1A screening. Specific is CD207. Okay. Culps, you are wrong. Niku, you are wrong. NASA, you are wrong. All of you are wrong. Naman, you are wrong. My question is light microscopy. All of you are answering for electron microscopy. Electron microscopy only big granules or tennis racket. My question was light microscopy. Light microscopic picture is grooved nucleus. Light microscopic picture is grooved nucleus. Light microscopic picture is grooved nucleus. Okay, please don't do this mistake again. Electron microscopy is Birbeck. Light microscopy is grooved nucleus. Okay? Right. That's it, Neha. Okay, very good. Now, in a 7-year-old child, there was a history of bedwetting and there was no other associated symptoms. The child was extremely stressed due to bedwetting. What is the initial and most effective therapy for this child? Answer. Sindhu, if you want to finish class now, I am ready to do it, no problem. Class till, as long as you tolerate me. That way, that will be the answer. So, Sindhu is asking me, A, 9 o'clock, B, 9:30, C, 10 o'clock, D, as long as you tolerate. Okay, right. Rewarding for daytime voluntary. So, whenever, okay, whenever any child is passing urine at night, soiling urine, the first thing is encourage them. The rule of 40. 40% fluid in the morning, 40% in the afternoon, 20% in the night. Okay, the step A is you need to reward. Don't punish, you need to reward. If it doesn't work, then bell and alarm technique. Once the underwear is soiled, alarm will be what will happen? Alarm will start, which will wake the baby. Okay, alarm for alarm, bill for bill, I don't know. Okay, imipramine we usually don't use. So answer is A followed by B. When will you use oxybutynin anticholinergic? When you will use oxybutynin or tolterodin? Rodin. When will you use oxybutynin or tolterodin? Okay, Xavier, a beautiful Xavier, very good, my dear boy, very good. Xavier was mentioning something about functional constipation. The most common cause for daytime enuresis is functional constipation, but not nighttime constipation. Okay, daytime. Or okay, and one more point is very good. Overactive bladder. Daytime, daytime. Okay, urgency can be treated with anticholinergic, which reduces the overactive bladder. Which reduces the overactive bladder. Oxybutynin and tolterodin. Okay, one set is over. Can I open the next set? Or you are all tired? It is almost 2.5 hours right now. If it is okay with you, let me open the next set. Let me wait. How many of you are saying yes and how many of you are saying no? I am okay with it. Right. Shall I? Okay, then. Okay, let me go for the next one. Set 2. Okay, you want any break? You don't want any Ucha break or Kaka break? Okay, let me give you 1 minute. Okay, you don't want any break. Your bladder is not full. I'll give 1 minute break. Okay then. Okay, right. Right. Okay. Shall we start? Right. An unconjugated hyperbilirubinemia was persistent for the last 3 weeks in a neonate. Yes, every day get to learn something new. Okay, so just one. Let me explain you one beautiful story that had happened. Shall I one kutti story? Are you all willing to hear one kutti story that will not last more than 2 minutes? A real story. Before that question, okay, sure, yes, because see, we are living in an era where many people are taking classes. I don't know how many of them are clinicians. The more and more you understand the basics, and when you apply in your practice without doing any investigation, without any doing a high funda workup, if you able to get the diagnosis, then that's the beauty of a clinician. Okay, 1 second. That's the beauty of a clinician. Okay, I used to teach my postgraduates. When they say, sir, what is the investigation of choice in this means, I never ever encourage them. I never ever ask such kind of questions. What is the investigation of choice? Don't do that. Whenever you read a subject in such a way, definitely you are going to get a good course in your entrance examination. And how you are going to read, let me tell you. Whenever you read a topic, you read in such a way that if I am in a resource poor setup, I am in a resource poor setup like a primary health center, how I am going to diagnose is based only on clinical examination without doing any investigations. One. Two. If the same child comes to a general hospital where a simple CBC, RFT, LFT is there, what are all the clues that I will get in that hospital so to diagnose that condition? Three, you are working in a medical college. You are working in a medical college. Now, what are all the things you will do to get the diagnosis? And finally, you are working in a tertiary hospital, how you are going to get the diagnosis? Very simple. For example, whenever you take a case of cystic fibrosis in a child, if I am in a primary health center, when any newborn with a prolonged jaundice, along with the direct bilirubin and the oily stools, why oily stools? Because it is associated with the pancreatic insufficiency. My diagnosis will be cystic fibrosis unless otherwise proved. This is when I work in a PhD. If the same child comes to GH, I can do a serum electrolyte. I can do a serum electrolyte. In serum electrolyte, what will happen in this cystic fibrosis patient? They will lose their chloride, sodium, everything in sweat. So what will happen? Sodium they lose in sweat, chloride they will lose in sweat. As a result of which you will get metabolic alkalosis along with hypokalemia and hypokalemia mimicking Bartter syndrome. Both Bartter and this one mimics hyponatremia, hypochloremia, metabolic alkalosis. But in Bartter syndrome, there is a problem in renal tubule, so there will be a polyuria. But in cystic fibrosis, you lose chloride in sweat, so you won't get polyuria. So whenever I get a case like Bartter-like picture without polyuria, my diagnosis is cystic fibrosis. Step 3, I go to a medical college. Now, what is the investigation of choice I will do? Yes, I have the chance to do a sweat chloride test. I will do sweat test to find out a sweat chloride of more than 60 milliequivalent per liter. Then I go to a topmost hospital. I will do a genetics to find out delta F508 or any other mutations. So, I think there will be so many. Okay. Okay. Without investigation, you can do. Okay, Xavier. Okay, right. So this is one. So each and every, I don't know, many of you are going to be either a pediatrician or a general physician. Okay, please listen to the parents. Please listen to the patients. When you sit quiet and listen to them, at the end of the history, you will get the diagnosis. Okay, so please think that you are going to read in such a way in your MD or DNB. You are going to read in such a way in your MD or DNB. I repeat, I will diagnose everything clinically. I will diagnose everything clinically. Okay, is it possible? Yes, it is possible. In Harrison, in the majority of the first topics will be based on symptom analysis. Majority of them will be based on symptom analysis. Concentrate on those symptoms. When I have A plus P symptom, my DD will be this one, this one, this one. I will rule out this one. Okay, so please, medicine is such a beautiful subject. Such a beautiful subject. Yes, it takes some time to learn. I agree. It takes some time to learn. Okay. It is a travel. Medicine is never ever a destiny. It is a travel, my dear boy. But there are so many good things that can happen in a medicine. The majority of problem that people facing in medicine are they are more and more reading. Someone is taking some video classes. I don't know how many of them have seen all those cases. It is there in the Harrison. But when you live with the case, you know the reason behind each and everything. Okay? So, so see, whatever you read, that you are going to see in your clinical practice, whatever you read. Okay? Once what happened in 2010, in 2010, while I was preparing for my final year MD examination. I was married at that time. I had a 4-year-old boy at that time, 2006-year-old boy at that time, 2010. I could not concentrate on reading. I was reading Nielsen, but I could not concentrate through the Nielsen and started reading OPGI. I read only OPGI for MD. But one such particular topic I was reading in Nielsen, differential diagnosis of Kikuchi-Fujimoto disease. I was depressed like anything. After reading that Kikuchi-Fujimoto disease, I was depressed like anything. So what I did, I closed the book and I went to a movie called Vennai Thandi Varuvai. Okay, because I was depressed. I don't know why these people are giving Kikuchi-Fujimoto disease. Okay, I don't know why. But when I joined as an assistant professor in ICH MMC, I had met a 9-year-old girl with a large cervical adenopathy. We did so many, it occurred in 2011, 14 years before. We did so many investigation, malignancy, TB, everything. We didn't get the diagnosis. We took the excisional biopsy, sent the sample from Chennai to Gangaram in 2012. Okay. One fine day when the report came, I was doing a bronchoscopy. The mother gave the report. I opened it to see Kikuchi Fujimoto disease. So what is the but such a beauty lies in your medicine man course. Whatever you read, you must be thinking that it is not there. It occurs in Caucasian population. Western, no. You are living with 150 crore population. Whether it is Harrison, Nilsson, Bailey, all those cases are revolving around you. When you don't know what it is, you can't find out. What the mind doesn't know, the eyes will not see. Okay, so always be proud of you for being a doctor. Read well, apply that well, speak well, communicate well. Communication is more important than your language. Always be friendly to your patient. Never ever you will be in a wrong place where people are angry with you. Never ever. The best thing that you are going to be saved from all those glitches is a good communication skill with the parents, with the patients. Okay, money is the byproduct, my dear boy. Money is the byproduct. You give the heart and soul to your course, you will get it. Don't worry. So read with confidence, love. And again, one more thing. Whenever people gets good rank, people used to ask me, sir, I am not getting MMC, I am not getting AIMS, I am not getting MAMC, I am not getting any good college. It is not so, my dear boy. It is not so. Okay, it is not so. Individuals will make institutions. I repeat, individuals will make institution. Right now, we don't have good teachers who teach you, who guide you clinically. Okay, you will be your own teacher. And remember, there is a one famous Zen statement. What is that? Whenever the student is ready, the teacher will appear. I repeat, whenever the student is ready, the teacher will appear. So don't worry. Wherever you go, in which distant part of India you go, whatever stupid medical college it is, if you are very, very sincere, okay, you can learn from that place, my dear boy. I repeat, individuals will make institution and not, and the reverse is not true. So love your course, read well, whatever it is, whether it is radiotherapy, anatomy, physiology, biochemistry, general medicine, pediatric, nothing matters. You need to love that course from your heart and soul. Do it. I repeat, money is a byproduct. Okay? Bus. More than 5 minute story. Okay, baby? Right. What does it mean? Shall we start? Okay, right. And one more point. And one more point. Xavier has said, for example, always ask for hematuria with the dysentery. Otherwise, you can diagnose a hemolytic uremic syndrome. Okay, one more point, my dear boy. One more point. So, what is the most common cause for community acquired renal failure? The most common cause for community acquired renal failure is what? Hemolytic uremic syndrome. What is the clinical manifestation of hemolytic uremic syndrome? Anuria. What is the clinical manifestation? Sudden onset pallor. That was missed. The clinical manifestation of hemolytic uremia, sudden onset renal shutdown and sudden onset pallor. Okay. Then in that pallor, it is Coombs negative. Second point is it is Coombs negative. And always urea will be high, creatinine will be high. Smear will show schistocytes. Smear will show schistocytes. Remember, as he mentioned, whenever you get a hemolytic uremia, either you can have diarrhea positive or diarrhea negative. Diarrhea positive usually in older children. That is E. coli 0157. But there is a separate category called diarrhea minus which occur in children less than 4 years. It is mainly due to antibody to factor H. Okay, antibody to factor H. So since he had mentioned about hemolytic, let me complete. And remember, don't give antibiotics in D plus. Don't give antibiotic because it will release the toxins from Shigella or E. coli and will make the condition worse. So don't give antibiotic, just supportive treatment. Whereas in case of diarrhea minus in children less than 4 years, the treatment is plasmapheresis to remove all those unnecessary antibodies. So usually what I teach, the triad of anemia, thrombocytopenia, and sudden onset elevation of urea and creatinine is hemolytic uremic syndrome unless otherwise proved. Okay, baby, shall we go for it? It has become a long story. Sorry for wasting your time. Okay, shall we go for it? Okay, so what is this answer? Rota Krigler-Najjar syndrome. Krigler-Najjar syndrome is lethal. Are you there or you slept because of the advice I had given? Hello? Boss? Are you there? Suddenly the crowd had become less because of the advice that I had given. Huh? Okay, right. Okay, so Krigler-Najjar 1. No glucuronide transferase. No glucuronide transferase. Death is the rule. Death is the rule. No glucuronide transferase. Death is the rule. Okay, for Krigler-Najjar 2, some glucuronide transferase you can treat with phenobarbital. Okay, you can treat with phenobarbital. Whereas Rotar syndrome, so these two are characterized by indirect bilirubin. Whereas Roto syndrome and Dubin-Johnson syndrome are characterized by elevated direct bilirubin, in which Roto syndrome normal liver histology, whereas Dubin-Johnson syndrome you will get black pigment, that's all. Okay, you know the answer is Dubin-Johnson syndrome, right? Next, all the following are features of cerebral palsy except answer. Today I am going to summarize some important new concept in a nutshell. So make it okay, right? So what is this? This is very easy. So what are also read it? Let me write. So read it, answer. Let me teach you simple basic concepts on CP. What happened? Simple basic concepts on cerebral palsy. So one. So you have spastic. All limbs are involved. Quadriplegia. Quadriplegia. Second one. Lower limbs are mainly affected. Spastic diplegia. One side of the body is affected. Spastic hemiplegia. So now tell me, spastic quadriplegia is the most common and the CT or MRI finding is multiple holes. That is cystic encephalomalacia. What is that called as? Cystic encephalomalacia. Cystic encephalomalacia. Spastic diplegia usually occurs in preterm. Preterm diplegia, lower limb is affected more than upper limb, so you'll get scissoring gait. So you will get scissoring gait. So you'll get spastic diplegia, you'll get scissoring gait. What is the thing that you will get in diplegia? In diplegia, you'll get periventricular leukomalacia. Very, very important. Very good, Aki. Periventricular leukomalacia. Spastic hemiplegia is usually due to neonatal stroke. That one area is gone in the MRA leading to cyst formation, otherwise known as porencephaly. And these all three are associated with increased tone. All three are associated with increased tone spasm. And finally, because of kernicterus, basal ganglia involvement. Kernicterus basal ganglia involvement, you will get an ataxic CP. Here MRI will produce basal ganglia hyperintense signals. Okay, so microcephaly usually occurs. Ataxia can occur in case of extrapyramidal cerebral palsy. Cerebellar, sometimes cerebellum will be affected, you can get ataxia. Hypotonia again in case of cerebellum, this is cerebellum. Ataxia can occur in extrapyramidal syndrome, microcephaly in mainly spastic quadriplegia. Placid paralysis is unlikely to occur. Placid paralysis usually occur in lower motor neuron palsy. That is the manifestation of spinal muscular atrophy. So the answer is not placid paralysis. Microcephaly, ataxia, hypotonia, all can occur. Yes, dear, yes, you are correct. Okay, then all the following are seen in cystic fibrosis. Just now I taught my kids except answer. I will be waiting for your answer. I will be waiting for your answer. All the following are seen in child with cystic fibrosis except. Answer. Very good. So, what is that name called? Pseudo-Bartter syndrome. This is called Pseudo-Bartter syndrome. Potassium will be low, chloride will be low, sodium will be low, bicarbonate will be high. Because this is contraction alkalosis produced by renin-angiotensin aldosterone system, but no polyuria. Whereas in case of Bartter syndrome, you will get polyuria because you lose sodium, chloride as well as potassium through sweat in pseudo-Bartter syndrome. Sweat chloride is not 70, sweat chloride is more than 60 milliequivalent per liter. It is not hyperkalemia, it is hypokalemia. Newborn, my dear students, newborn screening of test is immunoreactive trypsinogen. Because of mucus plugging, because of ductal dehydration, you will get obstruction leading to pancreatic damage. So, your immunoreactive trypsinogen, otherwise called as IRT. I repeat, your immunoreactive trypsinogen IRT will be very high due to pancreatic damage. That's why in US, apart from DNA analysis, this immunoreactive trypsinogen has become the neonatal screening test of choice. I repeat, IRT, neonatal immunoreactive trypsinogen. Immunoreactive trypsinogen is the neonatal investigation of choice or a screening test for cystic fibrosis. Screening test for cystic fibrosis. One more thing is fecal elastase. One more thing, fecal elastase. Immunoreactive trypsinogen will be high due to damage. Fecal elastase will be low due to pancreatic insufficiency. Immunoreactive trypsinogen is high. Okay, this is about cystic. This is about investigation IRT. Contraction alkalosis mainly due to dehydration. Because of chloride leading to sodium loss, both leads to contraction, leading to renin-angiotensin aldosterone activation. Aldosterone causes hydrogen excretion, leading to contraction alkalosis. That's it. This is called Pseudo-Bartter syndrome. What is the most common organism that causes catastrophe in cystic fibrosis? Tell me, what is the most common organism? It is Pseudomonas, followed by Burkholderia cepaceae, followed by Burkholderia cepaceae, followed by Burkholderia cepaceae. This can produce shock leading to Cepaceae syndrome. This is called as Cepaceae syndrome. And very important question is anti-pseudomonal drugs. I will be waiting for you. Can anyone, all of you, post anti-pseudomonal drugs? Anti-pseudomonas drugs. Anti-pseudomonal drugs. What are all they? Come on. Oral is Cipro. Oral is Cipro. IV cephalosporins. You have ceftazidime. You have cefaperazone. You have cefepime. Often asked question, anti-pseudomonal penicillin. And then BL-BLI. What is BL-BLI? Peptas, tazobactam, carbapenems. What are all the carbapenems? Miro and then imipenem. Other than that, you have astrionum, you have colistin, and more often inhaled drug that you use is Toba. Respules. Toba inhalers are used to reduce Pseudomonas colonization. My dear friends, 200% you will get a question from this. Third generation cephalosporin, ceftriaxone, cefotaxime do not have anti-pseudomonal activity. Very important. Okay, what is that? Another clinching point is your cefotaxime, no. Pseudomonas, your ceftriaxone, no. And what is that? Fifth generation cephalosporin, ceftaroline. Ceftaroline, fifth gen, that is also no action for anti-pseudomonas. Very important. Okay, very peptas. So ciprofloxacin, cephalosporin, ceftazidime, cefaperazone, cefepime, peptas, beta, BL-BLA is beta-lactam is inhibitor, and then carbapenems, imipenem and meropenem, astrionum, colistin, toba inhaler, pseudomonas colonization, right? So the answer is yes. It is not hypokalemia. Pseudo-Bartter syndrome, remember. This is very easy. What is the answer? This is very easy. What is the answer? So yes. So what is the clinical criteria for HSP? What is the clinical criteria for HSP? Clinical criteria, tell me. Clinical criteria for HSP is palpable purpura. Palpable purpura means vasculitic purpura, so platelets will be normal. Second, along with one of the following. Along with one of the following. What one of the following? DAAR. That is how I teach my kids. DAAR. So R stands for renal involvement manifesting as hematuria or proteinuria. Hematuria or proteinuria. Okay. A stands for, it's a form of IgA nephropathy. IgA deposits. Another A for arthritis. D for diffuse abdominal pain. Diffuse abdominal pain. So HSP is the most common childhood vasculitis. Childhood vasculitis. Platelets will be normal. So palpable purpura plus PDAR. P, diffuse abdominal pain, arthritis, IgA deposition, and renal. This is polyarthritis. Sorry, this is, what is that? Henoch-Schonlein purpura. Right. So what is this? WHO criteria for diagnosing severe acute malnutrition is answer. So, and also people are finding it difficult. Okay, my dear friends, people are finding it difficult to remember SLE criteria. Remember SLE. Okay, that slick criteria. I will tell you very easy way, because SLE is an multi-system inflammatory. Sorry, it involves multiple system starting from top to bottom. Because this question contains SLE, so let me try to complete SLE within a minute. How to remember the criteria, slick criteria. So point number one, what is this? Hair. Frontal alopecia comes under new criteria. Second, when you go down brain, in brain you can involve psychosis, seizures, chorea. Two, I am talking about SLE. So one is alopecia. Second one is brain, psychosis, seizures, chorea. Third one is skin. What is that? Malar rash, sparing nasolabial fold. Second one is discoid rash. Second one is again cheeklet discoid rash. So 4 points. Fifth point, painless oral ulcer. Fifth point, painless oral ulcer. Fifth point. Sixth point, you come to hand. You have non-erosive arthritis. You have non-erosive. Don't say it is wrong. It is not glomerular. Fifth point is non-erosive arthritis. Okay. So fifth. Sixth point, you come to serosa. So it can be pleuritis or a pericardial pleural effusion or pericardial effusion. Sixth point. Seventh point, when you go down. Seventh point, when you go down, renal. Either hematuria or proteinuria. Either hematuria or proteinuria. Then go to bone marrow. Three cell lines: anemia, leukopenia, thrombocytopenia. That's all. Is it easy or tough? Let me come again. Point number one, alopecia. Point number two, psychosis, seizures, chorea. Point number three, malar rash. Point number four, discoid rash. Point number five, painless oral ulcer. Point number six, what is that? Non-erosive arthritis. Point number seven, serosal involvement. Point number eight, what is that? Hematuria or proteinuria, renal involvement. Point number 9, 10, 11 is main for bone marrow, anemia, thrombocytopenia, leukopenia. So in that 11, if you have two along with a positive ANA, then it comes under SLE. Okay, right. So this is just to remember with respect to SLE clinically, right? So what is the answer? WHO criteria for diagnosing severe acute malnutrition is, what is the answer? Weight for age or weight for height? Weight for age or weight for height? Come on, A, B, C, D. So many of you have answered weight for height, and it is not weight for age. Very good. Severe acute malnutrition. Correct. Congenital toxoplasmosis commonly manifest as. Okay, let me give you certain things. One, where will you get diffuse calcification? Right answer. Where will you get diffuse calcification? In torch infection. One. Two, where will you get periventricular calcification? Where will you get periventricular calcification? Three, what is the only torch that can be associated with abortion? Four, that can be associated with abortion. Four, what is the all torch infection produces issues in newborn only during primary infection? That is, mother is pregnant, the child mother is affected for the first time, only during primary infection, except Next point, no role of serology in which infection? No role of serology in which infection? No role of serology in which infection? Okay, so diffuse calcification is, what is that? Diffuse calcification, toxoplasmosis. Periventricular calcification, cytomegalovirus. The only torch infection that can produce abortion is syphilis. All torch infection will produce catastrophe in newborn only when the mother is affected as primary infection. But reinfection and relapse can cause damage in two conditions. One is CMV, second one is syphilis. No role of serology in herpes simplex. Don't do serology. You need to rely on PCR analysis. Fifth point. Sixth point, PCR analysis. Then what a new thing I can teach you. Most common net came back 1 second. Can you see?
No, sir, off it. Camera off. सर ऑब्वियस ऑन कीजिए तो एक बार ऑब्वियस ओपन
OBS 1 second. Yeah, OBS open.
शो
1 second.
शायद सर इंटरनेट आ गया है
Huh?
इंटरनेट कंटिन्यू कीजिए सर चेक
We'll finish then almost 3 hours over.
शायद सर अभी जस्ट इंटरनेट आया वापस
Internet had come.
है ना सर कंटिन्यू करके देखते हैं आप
Okay.
होता है तो
Well, I'll try in YouTube. Hello? Hey, are you there still? Hey, are you there still, my dear boys? Okay. Now, okay, right. So let me start. Patra, I thought you must have gone to eat. Repeat from point 6. Array. Okay, then no issues. Okay. So, only, right. So, sensory neural deafness can be a late manifestation. Microcephaly can present from birth. So, these are all the things with respect to torch infection. Right. Then go to the next one. Again, what is this? Rubin-Johnson syndrome, the liver, the molecular. Point number 6. Point number 6. Most common issue, the most common manifestation of cytomegalovirus is microcephaly. Okay, but the late manifestation will be sensory neural deafness. Very important. The late manifestation will be sensory neural deafness. Right. So what is this in Dubin-Johnson syndrome? A molecular defect is due to. Can you tell me what is ATP7A? ATP7A, ATP7A, 7B, Serpina. What is these are meant for? Yes, many of you had answered. I agree. But for Dubin-Johnson syndrome, the molecular defect is 7A is, what is 7A? You tell me what is 7A. What is 7A? Very good, Aki. 7A is Minky Kinky. 7A is Minky Kinky. Okay. 7B. What is 7B? 7B is Wilson. Very good. What is ABC2 is Dubin Johnson. Johnson. What is Serpina? What is this for? Yes, I agree, man. What is the last one? You tell me what is the last one. You tell me the last one, my dear boy. The last one, Serpina, is alpha 1 antitrypsin deficiency, which is literally not there in India. Which is literally not there in India. Okay, which is literally not there in India. Which one? Alpha 1 antitrypsin deficiency. I have not seen any case of alpha 1 antitrypsin deficiency in pediatric age group. Right. So this is over. What is the next one? To measure preductal saturation in an infant who was born 3 minutes ago, would you place the pulse oximeter? Where will you place the pulse oximetry? Answer. Where will you place the pulse oximetry? Answer. Very good. Very good. So it is right upper limb versus any lower limb. Any lower limb. Okay. Subclavian. Right upper limb. Preductal. That is preductal. Let me write series of questions in which you are going to answer about cardiology. Okay, get ready. Get ready, my dear boys and girls. 1. Cyanotic patafat. This will be very, very useful for my kids. Cyanotic congenital heart disease with left axis deviation. Cyanotic congenital heart disease with right axis deviation. 3. Cyanotic congenital heart disease with massive cardiomegaly, massive heart. 4. Cyanotic congenital heart disease with cyanosis, no murmur on day 3. 5th, cyanotic congenital heart disease that mimics hyaline membrane disease at birth. Come on, start answering. Come on, dear. Series of question again. Other things what you have? Boot shaped heart. Second one is figure of 8. Part 8. Answer. Answer. Figure of 8. Boot shaped heart. Egg on side heart. Come on, answer. Cyanotic congenital. Remember, all cyanotic congenital heart diseases are associated with the right axis deviation. The only cyanotic congenital heart disease associated with the left axis deviation is tricuspid atresia. Is very good, Nikuma. Very good, Ra. Tricuspid atresia. Very good, Ra. Very good, Ra. Very good, Neha. Cyanotic congenital disease with the right axis deviation is usually tetralogy of Fallot because it is the most common. Cyanotic congenital heart disease with a massive heart. Answer. Nico Aki. Cyanotic congenital heart disease with a massive heart. Come on. Cyanotic congenital heart disease. The largest heart is 1, 2, 3, 4, 5. Come on, Niku, Aki. Answer, Tharani. Is what? Is Epstein's anomaly. Is Epstein's anomaly. Okay, very good, very good, very good, Aki Sapna. Cyanotic congenital heart disease. A3 cyanosis, no murmur. Answer. A3 cyanosis, no murmur. Answer. With day 3, no cyanosis, but there is no murmur. Chest is absolutely clear. What is that? Chest is absolutely clear. 1 second. In class, PW class. So what it is? That's it, ma. That's it. That's it, Nico. TGA. Transposition of great arteries. Cyanotic congenital heart disease that mimics hyaline membrane disease at birth. Anyone? That mimics hyaline membrane disease at birth. Who is that? It is total. And what is that? Total anomalous pulmonary venous connection infracardiac. Total anomalous pulmonary venous connection infracardiac. Boot-shaped heart, you know, TOF. Figure of 8, you know. What is that figure of 8? Figure of 8 is what? Supracardiac TAPVC. Supracardiac TAPVSC. Egan side is TGA. Egan side is TGA. Okay? Yes, white out lung is infracardiac TAPC. This is the absolute surgical emergency. This is absolute surgical emergency. Okay, baby, absolute surgical emergency. Then let me finish everything in this single page. 9. Congenital heart disease, no pulse, shock. Day 3. What is the diagnosis? 10. Congenital heart disease, no pulse, no femoral pulse. Day 3. Congenital heart disease without any pulse, brachial. So without any pulse is hypoplastic left heart syndrome. Is hypoplastic left heart syndrome. Whereas congenital heart disease with absent femoral pulses is coarctation of aorta. Is coarctation of aorta. Coarctation of aorta. Okay? Very good, Ra. Very good, Aki. Hypoplastic left heart syndrome. No brachial, no femoral. My dear friends, no brachial, no femoral. Very, very important. No brachial, no femoral is hypoplastic left heart syndrome. One more point. When you have no brachial, no femoral, that can be divided into two. One is no carotid bruit. No carotid bruit. That is hypoplastic syndrome. When you have carotid bruit without any forelimb pulses, when carotid bruit is present, it is critical aortic stenosis. It is critical aortic stenosis. That's it in a single page. Look at the MCQs we have covered. Okay, what else I can teach my kids apart from this? 7. Okay, remember, for critical aortic stenosis, critical pulmonary stenosis, the treatment of choice is balloon dilatation. Choice is balloon dilatation. Okay, balloon dilatation. Point 12. Whereas for critical coarctation of aorta, what is the treatment? It is not balloon dilatation. It is resection and end-to-end anastomosis. Resection and end-to-end anastomosis. 12th point. 13th point for my kids. resection, and so it is different for critical aortic stenosis, pulmonary stenosis. For recoactation, I repeat, my dear friends, for recoactation, you can try balloon dilatation, but not in the beginning. 13. Next to 14th, what is the other correction points? What is Japanese? What is Japanese procedure? What is Japanese? Japanese is used in TGA. TGA, what is the Japanese? There is no murmur, there is no shunting, as a result of which you create a shunt by doing balloon atrial septostomy. Balloon atrial septostomy. Okay, first point is balloon atrial septostomy. What is Japanese? TGA first step. TGA second step is Japanese, in which you are doing what you are doing. Okay, what you are doing? Right atrium is your aorta arises from left ventricle, aorta arises from right, and pulmonary artery arises from left. So what will you do in Japanese? Atrial switch. What is that? Arterial switch surgery. Arterial switch surgery is Japanese. Arterial switch surgery is Japanese. Okay, that's all. These are all the points that I want to give with respect to congenital heart disease, both cyanotic and acyanotic. Okay, right. And one other beautiful question, so often asked: duct depend. Is it okay, my dear boys and girls? Another beautiful point. I think my kids are little bit tired and not answering. Look at this 48-year-old guy. Okay, taking class by about more than 3.5 hours. Come on, answer. Okay, now duct dependent lesion. Duct dependent. Very important. Here, duct can be for systemic circulation. That is your coarctation of aorta, critical aortic stenosis. They are duct dependent, systemic. The next one is duct dependent pulmonary. What are all the duct dependent for pulmonary? Okay. So what are all the duct dependent pulmonary? It is tetralogy of Fallot, tricuspid atresia. Duct dependent pulmonary. Duct for mixing of blood. Duct you use for mixing of blood is TGA. So in all these cases, okay, see, first case will present with shock. This case will present with cyanosis. So in all these cases, you start prostaglandin E1 analog, the child will temporarily improve. I repeat, the child will temporarily improve. Whereas two conditions are not associated with, I repeat, two conditions are not, I repeat, two conditions are not as or duct independent MCQ. So what is duct independent lesion? That is, whether you give VGE1 or not, it won't produce anything. These two conditions are, one is total anomalous pulmonary venous connection, second one is truncus arteriosus. In these two conditions, whether you give prostaglandin or not, it is not going to produce any effect. It is not going to produce any effect. Okay, right. Okay, right. So, as far as possible, I tried my level best to discuss simple points on congenital heart disease. I bet 100% you will be getting a question on this. Okay, right. Then, which of the following is not a manifestation of necrotizing enterocolitis? Which of the following is not a clinical feature of necrotizing enterocolitis? So before that, let me start. So necrotizing enterocolitis is a manifestation of preterm, unlikely to occur in term. Occur unlikely. So stage 1, any preterm, stage 1 is very very important. Any child with abdominal distension, feeding intolerance or vomiting, and stool for occult blood. So this is stage 1. When a newborn you are feeding, when a preterm you are feeding, if the child shows vomiting along with abdominal distension, 2 stool for occult blood, it will be positive. Stage 1A. Stage 1B is frank blood. Stage 1B is frank blood. And then you have 2A, 2B. 2A is characterized by focal nematosis intestinalis, air in the intestinal lumen. Focal nematosis intestinalis. Whereas 2B is characterized by diffuse nematosis intestinalis. Nematosis intestinalis. One more question. Is there any radiological criteria for 1A and B? No, no, no. Whereas there is a radiological criteria for 2A and 2B, that is called as focal air column in intestine, diffuse air column in intestine. Very good, Mar. Very good. 2A, 2B. And remember, the clinical point is 2A absent bowel sounds. Absent bowel sounds. 2B is characterized by mass. 2B is characterized by mass. And finally, 3A, 3B. 3A clinical finding is erythema, edema, induration of abdominal wall, whereas, and then massive ascites. Whereas 3B is characterized by, what is that? Pneumoperitoneum. Because of perforation. That is. Because of, this is very very important. What is that staging called as? This is called as modified Bell staging. And remember, because of the sepsis, they will go for frank metabolic acidosis and not alkalosis. Modified Bell, yes ma'am. Okay. So abdominal mass is there, vomiting is there, erythema is there. It is not alkalosis, it is acidosis. Right? Then, in a newborn, what is the most common cause for HIV infection? It was taught so many times. It is usually perinatal transmission. It is usually perinatal transmission. Instead of transplacental breast milk or exchange, it is usually perinatal transmission, right? Postnatally, for the ductal closure, which one of the following is the main factor? You all know. Postnatally, for ductal closure, which one of the following is the main factor? Following is the main factor. It is nothing but increase in the partial pressure of oxygen. I repeat, increase in the partial pressure of oxygen. And another beautiful point, anatomical closure, whereas you have physiological closure of PDA. Can you tell me what it is? Anatomical closure usually takes about 10 days after birth, whereas physiological closure usually occurs by about 12 to 24 hours. Okay, physiological closure 12 to 24 hours. Anatomical closure 10 days. This is for ductus arteriosus, whereas ductus venosus usually closed by 7th postnatal day. A new point. Ductus arteriosus closes by anatomical closure, physical closure. Anatomical closure 10th day, physical closure, physiological closure 2nd day itself, whereas ductus venosus usually closes by 7th day. Right. Which of the following vitamin deficiencies present with the cardiac edema and neuropathy? I have already explained you many times. Many times. Pyridoxine. What is the manifestation of pyridoxine? Pyridoxine is peripheral neuropathy, as well as it is used in homocysteine. It is used in homocystinuria. What is the drug of choice for pyridoxine resistant homocystinuria? It was already taught you in my one-liners. It is beta betaine. It is betaine. Okay, right. Pyridoxine. Pyridoxine deficiency usually occurs in people taking INH. These are all the questions. Thiamine. What are all the points we told? Wet berry. You all know. Dry berry. You all know. But new points that I told you just now is infantile aphonia. Infantile aphonia. Thiamine is used in which metabolic disorder? Thiamine is used in maple syrup urine disease because it is a thiamine is a cofactor for alpha keto acid dehydrogenase, which is responsible for valine isoleucine and leucine, that is branched chain amino acids. Okay. Biotin, a beautiful drug. Almost 20 times this question was asked. Biotin is used in multiple carboxylase deficiency. Is used in multiple carboxylase deficiency. Remember, multiple carboxylase deficiency. Remember, biotin should be suspected in any child neuroregression. Any child presenting with neuroregression and what? Many child presenting with neuroregression and alopecia. Again, what another question can be very good, Nikuma, very good. Biotin can be avoided, can occur as a result of taking raw egg. So boil the egg. Boil the egg. Riboflavin, where it is used. Riboflavin is associated with circumcorneal congestion. Many people know about cheilitis glottitis. Apart from that, perinasal seborrhea. Apart from that, perinasal seborrhea, one MCQ. Second MCQ is circumcorneal congestion. Circumcorneal congestion, the deficiency. Circumcorneal congestion. Another important point, riboflavin. Very good, very good, Nikuma. Very good. Another good point with respect to riboflavin is it is used in mitochondrial oxidative pathway defect. Mitochondrial phosphate defect. Okay, right. So these are all the things that we had covered with this. Then the commonest indication for liver transplantation. The commonest indication for liver transplantation is extrahepatic biliary atresia. I repeat, extrahepatic biliary atresia. And some important points I would like to cover here is, remember what is called neonatal cholestasis. What is called neonatal cholestasis. So neonatal cholestasis means serum bilirubin lasting for more than 2 weeks. Point number one. Second point is direct bilirubin more than 20% of total bilirubin. Second point. Third point, it usually divides into non-sick baby and then sick baby. Non-sick baby is usually extrahepatic biliary atresia or choledochal cyst. Both can be diagnosed by USG. In extrahepatic biliary atresia, you will get triangular cart sign. Triangular cart sign. Treatment, it is not Kasai. Treatment is not Kasai. People say Kasai. No. Kasai should be done as a interim procedure within 60 days after birth. Treatment is liver transplant. Treatment is liver transplant. Transplant. Whereas choledochal cyst removal. Whereas sick baby, very, very, very important, usually associated with inborn errors of metabolism. It can be galactosemia. What is the clue for galactosemia? Urine non-glucose reducing substances. Urine. This question was asked in 2017, I think. Urine non-glucose reducing substances. One. Or it can be tyrosinemia. Or it can be tyrosinemia. Clue is elevated alpha fetoprotein. Or it can be due to herpes. Due to herpes. These are all very, very important with respect to neonatal cholestasis. Okay. Most common cause for liver transplantation is biliary atresia, right? At what age a kid can reach out to both hands to an object? So bidextrous grasp. Answer. So bidextrous grasp 4 months, unidextrous grasp as well as transfer of objects 6 months, and by about 8 months you will get radial grasp. You will get radial grasp. By about 9 to 12 months it become pincer grasp. By about pincer grasp. Okay, right. This is with respect to, okay, grasping the object. And remember, one more point I want to clarify here is what is called, what is that, hand regard. My question is, what is called a hand regard? Till what age it is present? What is called hand regard? Till what age is present? Beyond dash weeks, it is said to be abnormal. What is that? Whenever any child, usually children, kids, newborn, bring the hands over the midline and look into those hands. This is called hand regard. It is usually between 12 weeks to 20 weeks. Beyond 20 weeks, hand regard is said to be abnormal, and you need to rule out, cerebral palsy. Hand regard. I repeat, hand regard. Very good, Ra. Very good, Ra, man. Very good. It is 20 weeks. What about 3 months? Someone mentioned about 3 months. Let me give you a simple one more. What is that? Cortical thumb. Cortical thumb. Remember, this is thumb. When it is constantly adducted, it is called cortical thumb. Cortical thumb more than 3 months is also said to be abnormal. Cortical thumb more than 3 is said to be abnormal. Okay, right. Very good. It is present even without vision, right? Then Apgar score. Apgar score at 5 minutes after birth. Okay, heart rate 60 per minute. Heart rate 60 per minute. What is that? Normal 100. And then what is that? Look at there. Heart rate 60 per minute. Cyanosis, grimace, irregular grasping. So what could be it is? What could be the Apgar score? What could be the Apgar score? So, one by one, irregular gasping breathing. So, what does it mean? Respiration, irregular gasping breathing. So, 0 score. Okay. So, gasping breathing, 0 score. Grimace, score of 1. Grimace will be score of 1. Heart rate 60 per minute. So, less than 100 is 60 per minute. So, I will give you a score of 1. So right now I have heart rate, grimace 1. Cyanosis. Cyanosis, remember, cyanosis means they had not mentioned whether it is central or peripheral cyanosis. Remember, when your tongue is blue, you will be given a score of 0. When your peripheral is blue, you will be score of 1. I presume it is a score of 0. And respiratory rate, heart, they are mentioned. Respiratory rate, gasping, they are mentioned. Muscle tone, where is the muscle tone? They are not mentioned muscle tone. Let me say, what is this muscle tone? Active movements 2, flexion, some flexion 1, limping is 0. So if I put, so this is how you calculate your Apgar score. So many times Apgar score will be asked. So just remember this tabular column. The question did not mention cyanosis. The question did not mention one more thing. What is that? Muscle tone. So without this, unlikely to get the score of Apgar. Tone should be mentioned, right? Okay. In congenital rubella syndrome, most common heart defect is, you all know PDA. You all know it is patent ductus arteriosus. And remember, I want to tell something about PDA in newborn, often asked question. So PDA in newborn is usually classified into two. One is asymptomatic, another is symptomatic. Asymptomatic means CCF is there. In asymptomatic means symptomatic. Symptomatic means always medical closure. Always medical closure. Asymptomatic means again less than 1000 grams, more than 1000 grams. Less than 1000 grams medical closure. More than 1000 grams, wait till it becomes symptoms. Symptoms. Now, preterm PDA. I repeat, preterm PDA. Symptomatic medical closure, less than 1000 grams medical closure. What is the drug of choice for medical closure of PDA? Answer. What is the drug of choice for medical closure of PDA? What is the drug of choice for medical closure of PDA? I am waiting for your answer. Sudhir Panda, indomethacin. MD indomethacin. Niku indomethacin. Tarani, Marrow, wrong, 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 Suchi wrong, Marrow wrong, wrong. 2007 to 10, I was doing MD. At that time, it was indomethacin. So it is before Christ. IV indomethacin is not available, docs. So we had used Brufen. Now you are living in 2025. You know what is the drug of choice? The drug of choice is IV paracetamol. The drug of choice for PDA closure is IV paracetamol, my dear boys and girls. It is IV paracetamol. It is not Brufen. It is not indomethacin. IV indomethacin is not there in India. So we had been using Brufen, but now the drug of choice is IV paracetamol, my dear boys and girls. So write it down. Ruchi, come on. You said IO, no. Type it down. The drug of choice for medical closure of preterm PDA is IV paracetamol. Come on, in the chat box. So for term PDA, it is surgery, not surgery. So I'm sorry. So for term PDA, either coil, small means coil or device closure, or surgical closure like double ligation, usually by about 1 year. Term PDA will not be closed by no role of medical closure. No role of medical closure for term PDA. Medical closure for term PDA. Okay? Right. Just now I taught my children Egon string occurs in, what is that? Egan sting occurs in which condition? Transposition of great arteries. No man saying total anomalous pulmonary venous connection supracardiac. Karen Sabot TOF. What is scimitar sign? Scimitar sign is partial TAPVSC. Scimitar sign is partial TAPVSC. So yes, you all know it is tetralogy of Fallot. Okay. What is the during a trekking expedition a person develops headache and breathlessness followed rapid ascent to over 3,000 meters above sea level? Which of the following is not used in the treatment of this condition? Not used. Oxygen you will use, descent you will use. You need to produce tablet acetazolamide you use. You all know IV digoxin is not used in this condition. Right? Okay. Then, okay, what else? Okay, what advice should be given to students exposed to meningococcal, okay, meningococcal meningitis outbreak? Students, right now we had a case. I told you already, no? Right now, 5 days back, we had a case. A 4-year-old boy contact with his grandfather who went to Hajj. Grandfather who went to Hajj, usually it is meningococcal is there. That's why many people, many country ask you to have meningococcal vaccine before going to Hajj. The grandfather went to Hajj, he came back, he was vaccinated. Contacted his grandson, he was not vaccinated. Died within 3 days. Died within 3 days. You know, died within 3 days. Severe shock. The typical petike, severe shock and typical petike shock died. So it is not meningococcal vaccine. Two drugs can be used. One is rifampicin, another is ciprofloxacin. So that child would have been saved by giving either ciprofloxacin tablet or rifampicin tablet, meningococcal prophylaxis. Okay, and finally, what is this? A child belonged to low socioeconomic group brought to OPD with a swelling on the belly. He was fed rice water, rice milk most of the time. On evaluation, low serum protein, low albumin was detected. What is the probable? Kwashiorkor. Indian childhood cirrhosis due to copper utensil is not that common right now. Marasmus is energy deficient. Kwashiorkor is protein deficiency. Kawasaki disease is vasculitis involving cerebral arteries. Okay. Now another question to my kids. Another question to my kids. Kawasaki disease with coronary artery dilatation Z score of more than 10. So, what is the treatment of choice? 1. Steroids, 2. IVIG. What is the treatment of choice? The recent Nielsen guidelines. Kawasaki disease is a large coronary artery diameter of more than 10. What is the treatment of choice? Steroids, IVIG. Answer. You all know 2 gram per kilogram of IVIG should be started and it should be given over a period of 2 days. Steroids, Sudhir has stated IVIG, Tarani steroids, Dox IVIG. My dear friends, a KD with a Z score of more than 10, no Nelson state that a combination of steroid and IVIG. I repeat, a combination of steroid and IVIG should be given for Kawasaki disease with a Z score of more than 10. This must be new for you. Okay. And finally, below is the buccal. So whenever you have a rash, along with a spot enanthum involving second molar, invariably your diagnosis will be measles. Invariably, very good Neha, invariably your diagnosis will be measles. So some rash related question. Fever goes, rash comes, what disease? Fever goes, rash comes, what disease? Fever goes, rash comes, what disease? Roseola infantum or exanthum subitum. Fever increases with the rash. On fourth day, measles. Face is typically spad and rickettsial disease. Scrub typhus. Rickettsial disease. Face is typically spad. Toxic with petechial rash. Just now I told you meningococcal. What is noma? Can you tell me what is called noma? Gangrene of cheek occurs in severe infection, occurs as a result of measles. So again on measles, which day of fever rash comes? Fourth day. Incidence of SSPE 1 in 1 lakh. Most common complication of measles is otitis media and bronchopneumonia. Otitis media and bronchopneumonia. Okay. Finally, biliverdin is green in color. Bilirubin is yellow in color. So newborn greenish black discoloration of your stool is mainly due to bilirubin. Okay. Which of the following antibodies does not provide significant immunity in a neonate? Tetanus. That's why see BCG, OPV, measles. Sorry, BCG, OPV, hepatitis B you give at birth because they don't provide. Among the choice, polio is there. So OPV is not going to provide immunity, significant immunity from mother to the child. Okay, again, what is this? A 3-year-old child who has already received a vaccination against diphtheria at 16 months, so booster had received, is now exposed to diphtheria. One booster dose, no, my child had received 3 plus 1. So only I am going to give erythromycin to this diphtheria contact who had received all 4 3 plus 1 doses, 3 primary and 1 other. That's it. Okay, diphtheria. And what else? Of the total energy, how much percentage of energy should be saturated? Saturation means coconut oil. It should be very, very less. Okay, it should be very, very less. Okay, right. So probably saturated, unsaturated, as well as saturated, unsaturated. So you have saturated coconut oil, it should be just 7%. Polyunsaturated fatty acids, it is usually 10%. And monounsaturated fatty acids is usually 13%. With the linoleic acid, 30% of energy expenditure, and linolenic acid, it is 0.3 percentage. So these things are very, very useful. So saturated 7, for 10, monounsaturated fatty acid 30. It is not, linoleic is 3%. Linolenic is 0.3%. That's it. On evaluating a 3-year-old child with enlarged clitoris, this is very, very easy. I am going to complete with this. Okay. So congenital adrenal hyperplasia. Now I have precocious puberty. So what are all the things? Boys, girls, and then PP. These things we are going to see. 21 alpha hydroxylase deficiency. Boys will have precocious puberty. Girls will have atypical genitalia or ambiguous genitalia. Very, very important. Please listen to my dear boys and girls. PP will be low. Second, whereas in 11 beta hydroxylase deficiency, again, precocious puberty in boys, atypical genitalia in girls, whereas BP will be high because of deoxycortisol. Third, in 17 alpha hydroxylase deficiency and 1720 lyase deficiency, what will happen? Testosterone will not be produced. So you will get atypical genitalia in boys, normal genitalia in girls. But what will happen? Because of unhindered production, substrate will be converted into aldosterone. So BP will be very, very high. Whereas in 3 beta HST deficiency, dehydroepiandrosterone will be high. So this dehydroepiandrosterone will cause not much virilization in males as the testosterone that produces. So it is a weak androgen. So this is characterized by dehydroepiandrosterone production. So in males, it is characterized by hypospadiasis. In females, it is characterized by mild hirsutism. BP will be low. Wherever BP is low, in all these cases, you need to give hydrocortisone. Wherever BP is low, this condition, you need to give fludrocortisone. Investigation of choice is 17 hydroxyprogesterone levels. It is the most common cause for precocious puberty in boys. With this single slide, definitely you will be getting one question from this single slide. So I usually teach my kids, your 3 beta HST is a combination of the hypospadiasis in boys and hirsutism in girls. That's it, over. Okay. And finally, lateral wall defect is gastroschisis, midline defect is amphoulocele. Okay. Hypertrophic pyloric stenosis, we have already discussed hypochloremic, hypokalemic, metabolic alkalosis with paradoxical aciduria. And finally, to end with, again, let me reinforce a point on rickets. What is this here? Calcium is normal, phosphorus is low, parathyroid is normal. So what is the diagnosis? Hypophosphatemic rickets. Again, let me hypophosphatemic rickets. So let me complete. So in any case of rickets, look at the phosphorus. When phosphorus is high, look for PTH, parathyroid hormone. When parathyroid hormone is high or parathyroid hormone is low, parathyroid hormone is low, look, it is what is that? Chronic renal failure. Whereas when your parathyroid hormone is low, hypoparathyroidism. Okay, now if parathyroid is low, look for PTH. If PTH is normal, your diagnosis is X-linked hypophosphatemic rickets. If phosphorus is low and PTH is high, two things you need to see. One is 25 OH-D3. When it is low, it is nutritional rickets. When it is normal, look for 125 OH-D3. When 125 OH-D3 is low or 125 OH-D3 is high, 125 OH-D3 low is VDDR type 1. 125 VH is high means VDDR type 2. Type 2, as I told you, is lead to alopecia, and hypophosphatemic rickets is often present with dental abscess. That's all. 1 minute approach to rickets is over. Okay, over. And what is this? Generalized edema. What is this? A child with the height for age less than 2 standard deviation. Acute malnutrition means wasting. Chronic malnutrition means stunting. This child height for age is low. So this is a case of chronic malnutrition. Generalized edema, hypercholesterolemia, urine Nephrotic range of proteinuria. Nephrotic range of proteinuria. Okay. Remember, as per Indian guidelines, when you give prednisolone and it is not working for more than 6 weeks only, it is steroid resistant nephrotic syndrome. Okay. Another definition is more than 1 gram per meter squared per day. Spot PCR more than 2 is called nephrotic syndrome. We don't include cholesterol. Remember, cholesterol more than 200 and serum albumin. Albumin less than 3 grams per deciliter. Nowadays, serum cholesterol to diagnose nephrotic syndrome has been removed by Indian Society of Nephrology guidelines. What is this? A child present with fever, nuchal rigidity. The child is on ventriculoperitoneal shunt. Remember, whenever any child with ventriculoperitoneal shunt is developing neck stiffness or rigidity, it means that the shunt is infected. So what you need to do? What you need to do? You need to. So what you need to do? You need to take shunt tap CSF sample from it to diagnose shunt infection. In fetal circulation, which vessel carries deoxygenated blood back to placenta? Again, placental circulation. I don't want to let my kids lose with this difficult. Within a minute, I am going to complete this. What is this? Fetal circulation. So, placenta, from placenta through umbilical vein, oxygenated blood. This oxygenated blood bypasses the liver with the help of ductus venosus. With the help of ductus venosus. And from there it joins the IVC. From IVC, the blood reaches the right atrium. From right atrium, instead of going into right ventricle, it traverses across patent foramen ovale to left atrium because this is oxygenated blood. From left atrium goes to left ventricle. From left ventricle, it goes to aorta. From left ventricle, it goes to aorta, and from aorta, it goes to descending aorta. And then umbilical arteries to lower limb and finally reaches your placenta. Finally reaches your placenta. This is deoxygenated blood. Okay, this is to start with oxygenated. Now, what will happen to deoxygenated blood? So your deoxygenated blood coming from SVC joins the right atrium, and from there goes to the right ventricle, and from there goes to the right ventricle, and from there and from it goes to pulmonary artery. But lung is collapsed. You all know lung is collapsed. So from pulmonary artery, it bypasses through ductus arteriosus to descending aorta. That's all. Descending aorta. That's all. That's all. This is fetal circulation. Okay. What is this? A boy brought with seizures. 8 years back he developed seizure. 8 years back he developed rash. Probably it is a case of SSPE characterized by periodic complexes and IgM measles in CSF. IgM measles in CSF. Okay. Overman, last question. What is this? A male child. Remember, whenever weight is child is 1 year 4 months. So I will plot 1 year and 4 months. So I will plot here 1 year and 4 months. What is the weight of the child? 8 kgs. What is the weight of the child? So 1 year 4 months. What is the weight of the child? 8 kgs. So that is above -2 standard deviation. So I will tell the mother, don't worry. That's all. This is how you need to plot. Okay, finally, what is the next step in the management of a 1-day-old child not passing urine since birth? Simple, you need to give breastfeeding, not artificial feeding. Continue breastfeeding and observe, right? And finally, what is this? Preschool age, abdominal pain, vomiting, oliguria, periorbital puffiness, elevated urea, creatinine, potassium level. Remember one thing. Rule of 678. Rule of 678. When your potassium is more than 6, phosphorus is more than 6, calcium is less than 7. Calcium is less than 7 and uric acid more than 8. It is what? It is what? It is what? Tumor lysis syndrome. Ideally speaking, when you have raised urea and creatinine, when you have initially you start with hydration for previously formed uric acid rasburicase to prevent further uric acid production allopurinol. But when urea and creatinine is increased, better to do hemodialysis. The question lacks something. Better to do hemodialysis. What is this? Acute abdomen. Acute abdomen. What is this? Class sign. Intussusception. Intussusception. TSH level of more than 100 indicates what? TSH level of more than 100 indicates what? Primary hypothyroidism. For that you need to do radio tracer uptake study. So finally, whenever you have in a small revision on congenital hypothyroidism, so the first investigation is TSH is high, so iodine uptake studies. Iodine uptake studies. So in iodine uptake study, no uptake, ectopic uptake, and then increased uptake. Three things you can have. Ectopic uptake means ectopic thyroid. No uptake can be due to two things. In USG, thyroid is present. In USG, neck thyroid is absent. USG thyroid absent means most common cause thyroid dysgenesis. Whereas in USG thyroid present means it is antibody to maternal antibody to TSH receptor. This question was asked once. Okay. And then increased uptake means to urine iodine. Urine iodine high, urine iodine low. Urine iodine high means it is dysharmonogenesis. That is your thyroid peroxidase defect. Thyroid peroxidase defect. Low urine iodine means endemic iodine deficiency. That's all. Thyroid over. Again, this question we saw jerking movements, movement of limbs, regression of myelin, West syndrome, ACTH. Okay, again, 50-day-old child brought with recurrent diarrhea. Remember, up to 18 months, IgG antibody for HIV by triple test is unreliable. You need to put P24 antigen assay or PCR studies, RNA or DNA of HIV. So in this case, what is the test? Dried blood. 50 days old HIV transmission. How will you detect? Only by doing a PCR. A 7-year-old child brought with difficulty in walking and getting up from squatting position is, what is that? Duchenne muscular dystrophy, very bad prognosis, die in third decade. What is this? Loose stools, increase in frequency, skin pinch goes back very slowly. Very slowly means severe dehydration. That's all. For severe dehydration, 100 ml per kg. 70 ml per kg and then 30 ml per kg. 30 ml per kg less than 1 year, more than 1 year. More than 1 year, half an hour, less than one, more than 1 year, half an hour, less than one, half an hour, less than 1 year, 1 hour. 70 ml per kg, less than 1 year means over 2.5 hours, over 5 hours. More than means over 2.5 hours. Slow correction. So what is this? It is neither a gastroschisis nor an amphiloceal. It is an ectopic bladder. It is called bladder extrophy. It is called bladder extrophy. And finally, what is this? A child presented with breathlessness, unilateral hyperinflation of lung. Remember, my dear boy, unilateral hyperinflation of lung is, unless otherwise proved, foreign body. X-ray should be taken in expiratory film. And what is the treatment of choice? Which of the following statement is true? Flexible bronchoscopy is not used for removal. Rigid bronchoscopy is used for removal. Focal area of decreased air entry is suggestive of foreign body. Very good. In complete obstruction, ball valve nahi. Complete obstruction leads to collapse. Ball valve leads to obstructive emphysema. Child has laryngotracheal bronchitis. Laryngotracheal bronchitis is stridor. So the answer is B. Finally, a male child with the pain in the joints and abdominal pain. So what is that? On examination, palpable purpura. So HSP, what is the treatment of choice? Steroids. On 10th birthday, one child is having generalized body swelling, anasarca. Minimal change was diagnosed. Which of the following is true? Very good response to steroids. Light microscopy is normal. Only electron microscopy will show effacement of podocytes. HLA DQ2 and HLA DQ8 are associated with celiac disease, in which you will give gluten-free diet. Gluten-free diet. With this, I am finishing my topic for today. Thanks for your patient listening. Almost it is 4 hours and 22 minutes. I hope, I pray my children are going to get many questions from this discussion. All the best, all the best for you. Love you all. Bye bye. Keep in touch. Be a good clinician, man. Okay, right. Bye bye. Tata.